All right, council members, we are live on YouTube, and council member, you can begin when you're ready.
Good morning. I'm Robert White, council member at large and chair of the Committee on Government Operations and Facilities. Today is Friday, October 29th, 2021, and we're meeting remotely via the Zoom teleconferencing platform. The time is now 10:15 a.m. and I'm calling to order this public oversight roundtable of the Committee on the procurement process for the Medicaid Managed Care Organization contracts. On October 5th, 2021, the council was put in the incredibly difficult position of deciding between preserving the health insurance of 250,000 district residents during an ongoing public health emergency or rejecting a government contract whose procurement was deeply flawed from the outset. The council decided to put the health and safety of our residents first by temporarily extending the existing MCO contracts for 9 months. During the 9-month extension, the Office of Contracting and Procurement, or OCP, will start the procurement process all over again. We should never have been in this place. The Medicaid system should never have been put on the verge of collapse through a manufactured emergency. The series of missteps and failures that got us here defies comprehension. Those issues started piling up even before the last procurement process. Our Medicaid system has been unstable for years now, due to multiple re-procurements and redistributions of beneficiaries among MCOs. Companies that have signed up to serve our most vulnerable residents have at times refused to contract with one another for business and profit advantage, causing profound instability for the patients they've signed up to serve. The 2020 procurement was supposed to fix those problems through universal contracting, but instead, we only made the instability worse. Last December, the Contracts Appeals Board, or CAB, found the award of the MCO contracts was problematic on multiple grounds, from OCP accepting patently unlawful bids, whether according to past practice or not, to errors in evaluating and scoring the bids that were received. So CAB rightly told the administration to go back, rescore the bidders under the law, and give the contracts to the right entities. Rather than simply following the CAB's ruling, the administration did what the council and I explicitly and repeatedly told them not to do. They ignored the CAB ruling for months on end, instead repeatedly demanding that the council waive the ruling of the CAB and pass legislation to give a specific company a pass on its violations of contracting law and give OCP a pass on its flawed evaluation of that company. This is improper on so many levels. And for months, the majority of the council told the administration clearly, follow the law. As I feared, rather than backing down from a broken procurement, the administration manufactured an emergency by delaying action until the loss of healthcare for thousands of residents was imminent. This was done for political leverage, and it put the lives of hundreds of thousands of residents in danger. This summer, when MedStar learned that it would likely lose its MCO contract due to the required reevaluation, they threatened to exclude DC's 250,000 Medicaid and Alliance beneficiaries from its network of primary care providers and specialists, meaning that those on Medicaid and managed care would lose their doctors. In doing so, MedStar, a tax-exempt entity, showed itself to be an unreliable partner. This action doesn't hurt the city, it hurts the patients. The mayor, in her communications to the council and the public, predicted that the outcome of MedStar's decision would be devastating, potentially extending emergency room wait times beyond 24 hours, leading to numerous unnecessary deaths among district residents and breaking down preventative care for thousands in the middle of a pandemic. Rather than using the full force of the district's government to remedy those problems and find creative solutions, The administration instead doubled down on their broken procurement and issued an unprecedented and illegal public emergency declaration. Through that declaration, the mayor claimed the authority to unilaterally overrule the CAB
I'm going to step in for a moment. I'm Phil Mendelson, Chairman of the Council. It appears that Councilmember White has lost his internet connection. Sean, are you able to help with this?
Yeah, I'm getting in touch with him now and letting him know where we dropped off. Sorry about that, everyone. I will we'll get him back up shortly.
All right, so we will, I guess, sort of recess or just pause for a few minutes. And then Sean, let us know, or the council member will come back and let us know. So everybody pause for a few minutes.
Everyone, apologies for the delay. There was a brief power outage at the council member's house, but it's back up and he will be rejoining shortly. I assume it has to do with the weather we're having today, but we are going to be back on track momentarily. Apologies to all.
I thought it was like a Halloween theme or something. Oh, well.
Hi, Sean. We are on standby.
Thank you, Cable.
Sorry about that. We have a little storm that has caused some internet issues. If the committee team will let us know if we're good to resume, then I'll just pick back up. Sorry to my colleagues. Good morning.
Yes, Cable, whenever you're ready, let us know.
We're ready when you are.
All right, then we are resumed. Let me pick up where I left off, and apologies for the interruption. Rather than using the full force of the district government to remedy those problems and find creative solutions, the administration instead doubled down on its broken procurement and issued an unprecedented and illegal public emergency declaration. Through that declaration, the mayor claimed the authority to unilaterally overrule the CAB and extend the MCO contracts over all objections. That clear abuse of executive power left our system even more at risk and vulnerable to litigation that would very likely have sent the Medicaid system into more chaos. This is what the council was left to confront a few weeks ago, a clearly manufactured crisis arising from an utter refusal to accept and address issues by the executive branch. The council had no choice but to do what we could to safeguard the lives of our constituents and buy time for a new procurement process. As the chair of this committee, it is my responsibility to bring some transparency to what got us to this place and understand what we can and will do differently to ensure a legal, fair, and transparent procurement process over the next 9 months. Our goal is to ensure that the issues we saw over the last year with the MCO contract never happen again. As outlined in the Notice of Public Oversight Roundtable, we will discuss a number of issues relating to the procurement process, including everything that's happened over the last year on this contract and what our plans are for next year. We have to develop a plan for re-procuring these contracts that respects the law, leads to stability in the Medicaid program, and ensures quality services for our residents. This is not the first or even the second time we have failed to reach that goal, but we cannot keep doing the same thing and expect different results. So now is the time to learn from our past mistakes and get it right. I will now turn to my colleagues. I don't know what order people arrive, so I'm going to start with the chair of the council, Phil Mendelson, and then we will move to Councilmember Alyssa Silverman.
Thank you, Councilmember White, and thank you for having this hearing. This issue is of great concern to me for the reasons that you outlined, Mr. White, in your statement. There's been a lot of turmoil with regard to these MCO contracts. In fact, it's my understanding that the MCO contracts have been rebid or resolicited several times in the last half dozen years. This has not been a stable contract or service that the government has offered to 250,000 residents because of these constant resolicitations. And here we are again. Now, I support the fact that the mayor decided that she would go through a new solicitation and that between the council and her, this should happen within the next 8 months, since we are now through the month of October. But it does speak to a contracting process that has to do better with this next solicitation. Councilmember White outlined the problems with the last solicitation, and whatever our contracting officials may say, the fact of the matter is that the Contract Appeals Board did not find, after an evidentiary hearing, that the bid award process had been proper. Each contract is worth over $1 billion on an annual basis. So the chances are highly likely that with the next solicitation, whoever the losing bidder is, they have nothing to lose by litigating the process. So the process has to be done as carefully, as flawlessly as possible. And that's not to say that perfection is always attainable, but it is to say that the mistakes we have seen repeatedly over the last half dozen years can and must be avoided. Then this next solicitation, which I understand is about to hit the streets within the next few weeks, must be fair. It must encourage robust interest. One of the problems that I've come to realize with the last solicitation that I will be very concerned, and I would even say oppositional if it is repeated, is that universal contracting was required with the last solicitation, which sounds good. But what was it, in fact? It was that every bidder was required to universally contract with every hospital in the city. That's not what the federal government requires. The federal government requires that every bidder to be awarded an MCO contract must have adequate access. Why does this matter? Because what we have seen is that one of the hospital systems, has been a bidder, and that puts them in an unfair position with regard to the other bidders. This one hospital system, I'll just put the name out there, MedStar. I have a lot of respect for MedStar. My own medical care is through the MedStar system. But if universal contracting requires that a bidder must have a contract with every hospital, and MedStar is one of the bidders, then they're put in a favorable position where they can decide whether they will negotiate a fair and reasonable contract with the other bidders. So if we are to allow, and when I say the we, I mean the Office of Contracting and Procurement and the Healthcare Finance Agency, who actually is the one who is the contracting. If they want MedStar to bid, I have no problem with that. They cannot require that all the other bidders must have a contract with MedStar, or we will see probably a repeat of the turmoil we had this past year. Nobody advantaged by it. I'm not going to get into rights and wrongs. I'm just going to say that it was not a good procurement process this past year. And so this must be fixed. I'm hopeful that with the testimony that the committee receives today, that if there are other problems with the past procurement that must be avoided with this impending procurement, that those will come to light, that the Office of Contracting and Procurement, who is the agency technically responsible for the procurement, will listen and make sure that those problems are avoided at the front end so that we don't have to deal with this at the back end. If I'm sounding a little annoyed about all this, I am, because the council, I'm thankful, came up with a solution that the executive supported on October 5th, but we don't want to go through this again. And I want as many bidders as possible, 4, 5, 6, and I don't want allegations that have real merit to be raised at the end of this process. Let's get them out now, let's fix them now, and let's have a fair and robust solicitation. I've spoken more than I meant to, but I again thank you, Councilmember White, for having this hearing. I will not be sticking around for the whole hearing, so I can't say I'll be looking forward to the testimony, but I will be looking at what comes out of this hearing in terms of the testimony and the commitments from the executive. Thank you again.
Thank you, Chairman Mickelson. Councilmember Silverman, welcome.
Thank you, Councilmember White, and stay dry over there in Ward 4. So thank you very much for convening this oversight roundtable on the Medicaid managed care procurement. And I have to tell you, this is one of the weirdest things I think about district government. So this hearing should deserve a lot of attention for 2 reasons. It's about health insurance for our poorest, most vulnerable residents. It's access to health care for our families earning the minimum wage who are struggling in our city. And if we're going to close, we keep talking about closing the equity gaps, but if we're going to do it, if we're going to raise the COVID-19 vaccination rate in our city, then we need to have a good Medicaid provider network in place. So number one, if we're going to close the health equity gap, it's going to be through our Medicaid managed care program. Then second, as the chairman mentioned, I'm glad he did, it's one of the biggest contracts we have in district government. We're talking about $1 billion contract. So to sum up, we have our most vulnerable residents' health care at stake. And actually, it goes beyond that because of Medicaid expansion. So as we talk, 250,000 residents is more than 1 out of 3 people in our city depend on Medicaid. I mean, this is tremendous. Okay, so we have that. And then we have $1 billion contracts. So you would think a lot of time and attention in getting the contract and procurement process right. And you think all our colleagues would be here too. I mean, we're talking about a tremendous part of our budget. We're talking about a tremendous number of our residents. I get worked up about this because this is such a large and important service our government provides. But instead, it's been a mess. And as you said, Councilmember White, it has been incredibly chaotic and unstable. And that's because of all the characters involved. We had a contract appeals board say that the procurement violated the law, and they ordered us to do it again. And then we had one of our providers threaten to walk away from our poorest and most vulnerable residents, the patients, right? Unless they got the contract. And instead of the mayor and council coming together and saying, we need to solve this problem, I mean, we did in the end, after the mayor illegally declares an emergency and everyone's pointing fingers at each other. It's ridiculous. It's ridiculous. No wonder people in our city are cynical about our government. We need to deliver healthcare to our poorest and most vulnerable, and we need to make sure people do have access to our major hospitals and provider networks. I don't know if people realize just how close the district came last month to destroying the healthcare delivery system for 1/3 of our residents who depend on Medicaid and the Alliance. I mean, here's what bothers me, Councilmember White. You know who gets hurt in this? Not the lobbyists for the healthcare companies, because they'll do just fine. They're going to appear today and, we'll be fine at the council. And the mayor will be just fine. You know who gets hurt? Poor people in our city. That's who gets hurt, right? Because they're freaking out. They're going to lose their providers. It's not a game. Okay, now the chairman mentioned something, and I think we should pause on it, and I might have a different of opinion on this. So the problem is this: the chairman identified one of our contractors is, I think the term would be vertically integrated, right? So they have everything. They have a hospital, they have a physician network, they have a health insurance arm, and they have an advantage over everybody else because none of the other bidders, unless Hopkins is a bidder, but I don't think they have a health insurance arm, has a hospital network, has a provider network. GW does, but they're not bidding, I guess, on this contract. But so they have a competitive advantage here, and that's why they were able to threaten us. I mean, let's be for real. So MedStar said, unless we get this contract, we're taking away our hospital, we're taking away our provider network, which is like 40% of the physicians that take care of our Medicaid patients. So I guess maybe where my difference of opinion is we got to figure this out. MedStar is one of our largest providers, but they have a competitive advantage because they have the provider network and the hospital that our other insurers don't have. And they shouldn't be allowed to threaten us and bully us and say that they're walking away from the poorest residents in our city unless they get their $1 billion contract. So I've also gone on a lot longer and gotten a lot more passionate, and I apologize about my finger pointing, Chairman White, but this is a serious issue that deserves a lot of attention. And I get frustrated when some of the most important issues don't get the attention they deserve. Let me say something, and it's a little personal for me. I will be honest, because Medicaid is important to me and my family. This new procurement expands Medicaid to behavioral health. And if we're going to talk about trauma-informed public safety, trauma-informed public education, trauma-informed services, then we got to get the behavioral health part right. We got to. We can't let this mess happen again. And that's why I'm here. I'm also not going to be able to stay because I have the distinct pleasure of chairing the subcommittee on redistricting. But I understand that there has been a good process about the expansion of behavioral health services. It's been in the works for years through a Medicaid waiver application, state plan amendments, and I think there was a advisory groups, a stakeholder meeting, and so forth. But if we are serious about addressing trauma in our city, those who need the most help and resources are our residents who depend on Medicaid. We got to get this right. So I really thank you for your time and attention, Councilmember White. It looks like you might have left the hearing again. I don't see you on my screen. So I'm going to ask the committee, should I just pass the baton to Councilmember McDuffie?
Yes, please. The council member's power flickered again, and he asked the Councilmember McDuffie begin with a statement. Apologies.
Okay, very good. Well, thank you very much to Councilmember White, wherever you are. And good morning to you, Councilmember McDuffie.
Good morning, Councilmember Silverman, Chairman Mendelson, and to Chairman White. Thank you to you and your staff for holding this hearing. I think you just texted us to let us know what's going on. So I appreciate the update, Chairman White. But in all seriousness, one of my top priorities since becoming chair of the Council's Committee on Business and Economic Development has really been to advance policies that support our local firms and ensure transparency, access, and accountability. And to that end, I've introduced or supported my colleagues' introductions of multiple pieces of legislation to improve and strengthen the district's certified business enterprise program. And anyone familiar with my committee's activities will know how seriously I take oversight and engagement with the district's Department of Small and Local Business Development and its role in the CBE and SBE programs. However, the fact is the success of those programs requires a multi-agency effort, like many of the programs that people rely on in the District of Columbia. And I am concerned that the Office of Contract and Procurement's performance has been woefully insufficient in this regard. I am delighted to read in the Chief Procurement Officer's testimony, however, that OCP's enhanced measures, quote, to ensure that the crucial delivery of healthcare services to the district's residents, close quote, for the forthcoming Medicaid solicitation that would include behavioral health services, I'm quoting again, is not delayed by any interruptions in the procurement process, close quote. Now, emphasis added by me on that phrase. And I'm also pleased to read that OCP will be working closely with DSLBD to ensure CBE participation and to prevent unreasonable delays or issues in the procurement process. I will admit, however, that I am skeptical of this rosy outlook. Frankly, I'm concerned about OCP's faithfulness to the district's contract and procurement laws, which is why I'm pleased that Chairman White is holding this hearing today. It concerns me that the Contract Appeals Board found that the executive violated procurement laws and regulations, as well as the terms of the MCO solicitation. The CAB also found problems related to the actual scoring of contracts by OCP. I think in the midst of all that we've been through over the last more than a year and a half of this saga, people have forgotten that the CAB found a myriad of problems with the solicitation that was previously issued. For over a year, the executive has alleged that OCP has long misinterpreted the CBE law by allowing the submission of CBE subcontracting plans at the BAFO, at the best and final offer stage, instead of the initial bid submission. Yet the solicitation doesn't convey that misinterpretation. The solicitation expressly instructs bidders to submit their CBE subcontracting plans with their bid submissions as stated in the CBE law. The executive has also repeatedly indicated that MedStar relied on this misinterpretation, which means that they were told by OCP or somebody at OCP to ignore that provision in the solicitation, all while other competitors were subject to the terms of the solicitation and the law. Add that up and see if it makes sense, right? It concerns me that MedStar plays under a different set of rules as far as this solicitation has gone. And while I believe the goal of universal contracting has value in our Medicaid system, it concerns me that awards are based on who contracts with MedStar hospital system. I'm not going to go into all the details that Councilmember Silverman went to about the structure of MedStar and the outsized role that they play in provision of healthcare in the District of Columbia. But fundamentally, there is unfairness baked into the procurement process if MedStar is the gatekeeper of who ultimately receives awards. And so I want to make it perfectly clear that this is not about MedStar's ability to make business decisions, but it should be unacceptable to everyone that those business decisions can threaten the district's entire healthcare system without any safeguards in place. And so, again, I look forward to today's hearing as an opportunity to shed further light on OCP's plans with this procurement and to obtain real solutions to implement true universal contracting. Again, thank you to Chairman White and your committee staff. Like my colleagues, I won't be able to stick around for the entirety of the hearing. I'll try to pop in and out, but I will have staff monitoring the entirety of the hearing. And so thank you, Chairman White, and thank you to my colleagues for your statements today, but also for your actions and your oversight and your vigilance over the last more than a year of this process.
Thank you very much, Councilmember McDuffie. Before we start public testimony, I do want to just quickly lay out the ground rules for public witnesses. Everyone should have received a copy of the witness list yesterday. I'm going to call witnesses in the order they appear on the list. When I call you, you will drop out of the hearing momentarily and you will return as a panelist, at which time you'll be able to unmute yourself to testify. Public witnesses are provided 4 minutes to testify. And we'll call up our only panel of public witnesses now. Ambrose Lane, Chair of the Health Alliance Network, Adrian Jordan, Chief Executive Officer of AmeriGroup District of Columbia, and Frederick Cook on behalf of MedStar Health and MedStar Family Choice.
Are you ready, Chairman?
I am. Welcome.
Okay. Thank you, Chairman White. And good morning to the other members of the council that are on this committee. My name is Ambrose Lane Jr., and I'm here to testify for the Public Oversight Roundtable on the procurement process for the Medicaid Managed Care Organization contracts. I'm a Ward 7 resident and current chair of the Health Alliance Network, the largest community-based health advocacy organization in the District of Columbia. We have over 100 partners that include hospitals, managed care organizations, and from time to time, MedStar Family Choice, universities, advisory neighborhood commissioners, faith institutions, community residents, pharmacies, and both for-profit and nonprofit health entities. I wanted to express my thanks to Chairman White for holding this public roundtable. That being said, and I assumed that I had 3 minutes and not 4, so I may be shorter on my on my testimony.
Never a problem.
I've never been accused of being short. So in any case, 3 minutes is not enough time to have a full discussion about what went wrong in the most recent procurement and contracting process for Medicaid managed care. From alleged glitches, discrepancies, and contradictions in the procurement process, to the Contract Appeals Board rulings, to the actions of both the executive and legislative branches, it is abundantly clear that the system is broken, or at least close to being broken. We have had an emergency declaration by the mayor, a letter of disapproval by the council, a CAB ruling, continuing legal complaints, corporate bullying, and an unprecedented awarding of a sole source contract. It was the actions of MedStar Health, however, that prompted the Health Alliance Network and its allies to file a formal complaint with the U.S. Department of Health and Human Services Office for Civil Rights. That complaint is still pending. In their testimony, MedStar Health will deny bullying, stating that their decision to end discounted pricing to the remaining MCOs was market-driven. Nothing could be further from the truth. In fact, the decision to send the letter to the remaining MCOs happened just 9 days after the decision of the contract officer. The OCP will tout that what's included in the new procurement, behavioral health, which is a good thing, but it does not guarantee in any way that we won't be right back where we were if MedStar Family Choice is not chosen in that process. The solutions to these problems requires action by the DC Council. First, the council must enact legislation creating a cost control board or cost control council similar to that of Maryland, that A, approves guaranteed contracting and determines fair pricing rates across the hospital MCO spectrum for Medicaid managed care contracts, and B, creates revenue sharing models and that access the same spectrum to ensure equity and balance. Until that legislation is achieved, however, the council should immediately pass legislation that either mandates contracting between hospitals that are participating in the Medicaid program, or set as a condition for the receiving or renewal of a certificate of need, executed contracts between participating hospitals and contracted MCOs. And that is the end of my testimony, but I would like to comment on some of the testimony that is upcoming at a further time. Thank you.
Thank you very much. Adrian Jordan, welcome.
Sorry, Mr. Chairman, trying to get off mute here. Good morning, Chairman Robert White and members of the council. My name is Adrian Jordan, CEO of AmeriGroup DC, and I'm pleased to provide testimony today on the procurement process for the Medicaid managed care contracts. Group has over 30 years of history and experience serving Medicaid members and across 23 markets. In 2017, Group DC was selected as one of 3 awardees to provide Medicaid managed care services to the residents of DC. The road that led us to the most recent procurement and topic today was very well articulated by members of the government, DHCF, and members of the council. And everyone knows the critical changes needed to be made to ensure the stability of the district's managed care program. Group fully supported the calls for change to a program that saw widespread member migration in which some of the sickest members enrolled into just one MCO. Unfortunately, these programmatic fixes had the unintended consequence of injecting implicit bias into the procurement process. At the end of the most recent RFP process, Group DC noticed several discrepancies in the evaluation. Following the proper procedures, we filed a protest with the CAB and began outreach to the council to warn against a premature award, while a very legitimate protest was before that board. Ultimately, the contract would be approved passively, and 2 months later, the board sustained our protests. The CAB found that the district had violated the terms of the solicitation and district law and went further by stating that Group DC may have been awarded a contract had the district followed the law. With the CAB's ruling and the proper process followed, we fully expected a prompt reevaluation. However, for 9 months, at council hearings, news articles, and other outlets, we heard again and again that no matter what the law stated or the results of rescoring, Group DC would never be selected as one of the 3 MCOs. Over the last 10 months, we've seen legislative proposals that sought to undermine the CAB's ruling. Legislation that required the timely completion of the reevaluation was simply ignored, and ultimately contracts were awarded in violation of the CAB's order, the results of the reevaluation and district law. While narratives surrounding this procurement was dominated by talks of a CBE subcontracting requirement, that was never mentioned in the CAB's ruling. In our view, the CAB's ruling highlighted the implicit bias that exists within the new proposed provisions of the RFP. These provisions unfairly give a competitive advantage to vertically integrated health systems by requiring all MCO contractors to have an agreement in place with such entities that also serve as their direct competition. The procurement provides these organizations with a muscular position to improperly steer the district's largest procurement. Put plainly, such provisions allow a third party, not the district, to choose who can be an MCO and who cannot. As a recent example of this, we recently received a debrief from OCP following the reevaluation. The debrief states, Group not being able to secure the hospital agreement with MedStar Health was a continued concern of the CO, and thus Group received a reduced ranking of minimally meets the applicable solicitation requirements. Additionally, in this debrief document, we received the scoring of 3 of the 4 offers, which indicated clearly that we had been docked 4 points for failure of having MedStar network. This deduction eventually gave us an equal technical score with another MCO who was ultimately awarded a contract. The only negative response we could see was that we didn't have MedStar. In the end, we all witnessed MedStar being awarded a sole source contract, despite the fact that OCP had deemed its proposal ineligible, while Group DC, a top 3 responsive offerer, was not selected for award. It's no secret that Group DC was not awarded an MCO contract solely because of MedStar Health was not currently in network. This has been telegraphed and said for months. Without a procurement process free from bias with a level of fair and anti-competitive landscape, we may very well find ourselves back here in 9 months. What has transpired over the last year is regrettable and unfortunate. A system exists when an offeror can have a highly rated, qualifying technical score, a preferably low cost to the district, and yet a lower rated or even rejected offeror could exercise its muscular position and usurp that offeror's award. This could happen to any qualified bidder or multiple bidders in the next MCO procurement and is a strong deterrent to any company looking to do business in DC. The council should enact measures to ensure such unacceptable bias does not find its way into the new RFP or any other RFPs so that the highest rated offerers can actually win the contract awards they've earned to serve the residents of the District of Columbia. And with that, that concludes my testimony. Thank you, Mr. Chair.
Thank you very much. Mr. Cook, welcome.
Thank you, Chairman White. Good morning, Chairman White and members of the council. I'm Frederick D. Cook, Jr., and I'm outside counsel to MedStar Health and MedStar Family Choice with respect to providing testimony on this matter today. With me today are Ms. Regina Knox Woods, Vice President of Government Relations for MedStar Health, and Ms. Leslie Lyle Smith, Executive Director of MedStar Family Choice. And because we're all here together in the conference room, we're wearing masks to maintain the health protocols required of our company. We're happy to be here today, and we've submitted written testimony. And I would like to summarize some of that as we go forward today to talk about what MedStar Health and MedStar Family Choice are and what they've done here in the district and what our roles have been in the recent procurement. As a nonprofit organization, MedStar Health operates 3 district-based hospitals, MedStar Washington Hospital Center, MedStar National Rehabilitation Hospital, and MedStar George Washington University Hospital. And we provide more health services to the district's disadvantaged population than any other health provider in the district. With respect to MedStar Health, during the COVID-19 epidemic, MedStar Health played a critical role in the district's response to that pandemic. First, developing testing locations in the district, operating the mass facility at the Walter E. Washington Convention Center, Arena Stage, and other places in wards throughout the city. We worked with our infectious disease specialists to use monoclonal antibody treatments for people who were suffering the effects of COVID-19 infection. We adapted and created new telehealth methodologies to keep people from having to come to emergency rooms to provide help. We made it possible to receive that help, telemedicine help, at no cost to the beneficiaries. We waived fees in that regard. We have a community benefit contribution to the district for 2020 of $261.9 million through our 3 hospitals located here in the district. Those community services include things like the DC Safe Babies, Safe Moms initiative that is used to help mothers with newborns through age 3 to be healthy. We have MedStar Hospital Center working to sponsor Living Well and chronic disease program to provide workshops to manage health for conditions such as cancer, depression, anxiety, diabetes, heart disease, obesity, and much more throughout the city and to our senior citizen population. MedStar Georgetown University Hospital, however, provides food services to at-risk families, and through our kids' mobile medical clinic, mobile facility in wards 7 and 8. MedStar National Rehabilitation Hospital helps citizens with spinal cord disabilities through various grant programs to receive assistance, and we've done that with more than 200 individuals. MedStar Health has, since its current formulation, roughly 1999, provided health care in the district to many of our underserved citizens. And as I said before, more than any other provider. We have a long-standing commitment to the residents for this health care. And we appreciate the opportunity through the MCO program to provide that service. Some of the things that have been said this morning about MedStar bullying, MedStar utilizing its market power, just are not factually accurate. And we're happy to respond to those questions, but we received no special treatment from OCP. We didn't ask for any, and we did not ever refuse or threaten to terminate service to our medically disadvantaged population. It's sort of an inconceivable notion that we would do that given our history here in the city. What we did do was to try to restructure our relationships with other insurers, which we typically do when those contracts were about to end, as these contracts with these 2 insurers, AmeriHealth and First Choice, were about to do. We are absolutely happy to play by whatever rules the council and the OCP put out. We will perform as required, and we have always done that. But this notion that MedStar somehow has threatened or bullied the district is just inaccurate in total. But I'm happy to answer questions. I know I've gone beyond my time, and I apologize for that, but we're happy to answer any questions that you or the members of the committee might have. Thank you.
Thank you all very much. So I'm gonna get to this issue. I was just gonna wait a little bit, Mr. Cook, to get to this issue, but I think it would be helpful to clear it up since you mentioned the bullying notion in your testimony. So in your written testimony, you stated, and you kind of summarize this in your verbal testimony, that that the notice of termination for your provider agreements was not a threat, but rather that this is the type of contract notice that's normal business, and was that you initiated it to sort of begin discussions or begin negotiations. But I guess my concern or confusion is that if this was normal business practice to initiate renegotiation in this way, can you explain why the mayor used this sort of prediction of imminent catastrophic collapse from MedStar's decision as the justification for her declaration of a public emergency on September 1st? So clearly the mayor thought you were serious, and you're saying, it was not a threat. Help us understand that.
Sure, I cannot tell you what was in the mayor's mind. We did not speak with the mayor to give her any advice, but our letter clearly says, and let me back up and explain. The provider agreements we had with AmeriHealth and with Care First were about to expire in November of this year. We sent the letter in August, giving roughly 90 days notice that we wanted to, as we could do under the terms of the agreement, provider agreement, that we wanted to renegotiate the rates. We did that because, one, those agreements were about to expire. COVID-19 changed the world for healthcare providers in a lot of ways, and we needed to readjust the rates. It had the unfortunate effect, because of the timing of the notice that we had been given, that we would be terminated as an MCO provider effective September 30. That meant that if we were no longer a MCO provider, we would have to have a different relationship with AmeriHealth and Care First. The letters clearly state that we wanted to renegotiate rates, that we wanted to get those rates negotiated so that, and I'll read this, so that we were committed to working with you as quickly as possible to reach an agreement, to allow for continued participation with your plan without disruption to your members or patients. It was never said in the letter that we were going to withdraw from providing care to Medicaid beneficiaries or enrollees. It doesn't make any sense as a business plan. It doesn't make any sense for MedStar to do that, since we're so integrally involved in providing healthcare across the city. Some people who I can't.
What was the date of that letter?
One letter, the letter to AmeriHealth, the letter to Care First was dated August 20, 2021. The letter to AmeriHealth was also dated August 2021.
Okay. And did MedStar say anything publicly to clarify? Because the notion from the mayor on September 1st that MedStar is going to, take his ball and go home was in the news very quickly. When did MedStar work to clarify that it was not your intent to do that?
Sure. Almost immediately, when we began to be accused of taking our ball to go home, to use your phrase, we issued a press statement indicating what we had said in our letter. It was carried, I think, WTOP and several other media outlets covered our response. It did not, however, get the kind of attention that we're going to take our ball and go home got, because that obviously was much more critical. Another thing I think we need to keep in mind is it's difficult to bully if you're MedStar, AmeriHealth, or Care First. They are much larger corporate enterprises. They're several times larger than MedStar. So they're not really likely to take a threat from us, this as a threat from us. But it wasn't a threat. It was simply said, we need to reset rates, and we look forward to setting those rates so we both can continue to provide service to your patients. It was never a threat to withdraw from the program.
But we do know that, Mr. Jordan testified that AmeriHealth, AmeriGroup one of the ways they got docked in their evaluation was their inability to contract with MedStar. So I would say that that contradicts, your statement that MedStar is not in a position to bully.
No, sir. No, sir. That's just inaccurate, Mr. White. You have to look at why because at the time that Amera Group entered into the process, the procurement process, and had to identify as part of its RFP response what its provider agreements were. At that point, they did not have an agreement with MedStar. But to say that it was because MedStar attempted to keep them out of the program is inaccurate. That's just not true. It is true that they did not have an agreement, but it is not true that MedStar kept them out because MedStar wanted to try to get some competitive advantage. Those two things are not necessarily true together.
So how does MedStar determine who it will, like who gets agreements and who doesn't? How do you determine that?
Sure. The agreements are a negotiation with each provider, each insurance company in this case. And why that agreement did not come to closure with Amera Group, it's sort of complicated. I can't tell you all the details because I wasn't involved directly in those conversations at the time. But it takes two to have an agreement, and it can't be that you get an agreement simply because you show up and ask for one. It's a negotiation, and if you agree to the terms as Care First did and as Amera Health did, we have an agreement. If MedStar wanted to try to maintain a competitive advantage against insurance companies, we never would have reached an agreement with Amera Health or with Care First.
So is it fair to say your testimony is that MedStar's intent was not to bar access to your facilities and provider network in the for managed care enrollees?
That is absolutely correct. Yes, sir.
Okay. So if MedStar doesn't prevail in the next procurement, is it your expectation that MedStar would not bar the other managed care enrollees from your provider network and facilities?
Yeah, I think that's correct. I don't think we have any intention of doing that. The negotiations are difficult. It takes time sometimes to reach agreement, but we have no business advantage, no business intention to bar other MCO companies from participating in our network if we were not an MCO, or even if we are an MCO.
So for someone who's not an expert in this, there could be a bar, as in, MedStar could say, you can't use our network, or there could be sort of a functional bar where sort of the MedStar negotiates rates that aren't doable for providers. How should I, as a layperson and people watching this, how should we understand MedStar's position going forward?
MedStar's position, I think, should be understood to be one of a participant in an industry that will negotiate arm's length transactions with other participants in the industry that work to the mutual benefit of the two sides negotiating the agreement. The agreements are bilateral. All the agreements are not literally the same, but they are within the same order of magnitude. So if we don't threaten to withdraw from the program. What we do is we negotiate agreements at arm's length. And we've done that with lots of providers. We've done that with George Washington University. We've done that with Sibley Hospital. We've done that with small groups of physicians and providers. That's what we do. It doesn't make any sense for us to try to not negotiate with people, not to reach agreement with people, because then it doesn't work for our patients. It doesn't work for the healthcare system in the district. And so that's sort of counterproductive. So while these negotiations are sometimes hard, the idea is always to reach agreement.
Can you send the committee a copy of the letter or letters that you sent that you referenced in your testimony regarding the renegotiation?
You mean the letters to AmeriHealth and to Care First, sir?
Yes.
Yes, sir. Happy to do that.
Thank you. And what was the date of those letters again? I'm sorry.
August 20, 2021.
Okay. Did MedStar have conversations with Deputy Mayor Turnage or others from the administration before those letters were sent?
No, no,
About the renegotiation?
no.
Okay. And last question on this particular issue. In the middle of a pandemic, when Medicaid patients had just been sort of reshuffled, so the district is vulnerable because of a pandemic. Providers are vulnerable because there's not a lot of time left to comply with the CAB's ruling. Do you think it was maybe not the appropriate time to initiate renegotiations given these circumstances?
Well, I think that's a little bit complicated because, as I said before, the pandemic had changed the world for healthcare providers in a lot of ways. Costs had really radically changed. So those provider agreements that were negotiated before the pandemic occurred were about to expire in November of 2021. Those contracts also provide a 90-day notice or thereabouts for a termination that generally is used, traditionally been used, to reset rates for the contract period. So yeah, that was unfortunate, but the economic realities were that those rates for us and other providers, we weren't the only ones who sent those kinds of letters. So they had to be, we thought they needed to be reset. But you should know that MedStar has agreed to rescind those letters dated August 20, and to continue the rates of the existing provider agreement through the period of the emergency contracts. Because we want to see what the world will look like on the other side of the emergency contracts. So it's not an effort to jack up rates or to cause disruption. It's the business sensical thing to do when the world, when you negotiated the agreement, didn't have pandemic, now has pandemic.
Is my colleague, Councilmember McDuffie, here? And if so, do you have questions? I have more, but I know I've gone over my time. All right, we have I know there's another meeting, so members may not be there. Mr. Lane, let me turn to you for a moment. Given the situation the district was in September with the initial period of the MCO contracts coming to an end, the mayor had declared an emergency, and illegally so. What do you think the council should have done? What do you think would have been the most appropriate action of the council at that point?
Well, I will certainly tell you my thoughts on what should have happened, but I want to respond to Mr. Cook in what he said, and I just take issue with it, and I take.
Let me do this. I'm going to let you do that. I'm just going to ask you to be brief because
okay.
I got to make sure I'm directing the hearing.
Correct.
Thank you.
I just take issue with it because in the statement by the chief of the office by George Shutter, the director of the Chief Procurement Office, in his statement, it says that the Procurement Review Committee reviewed and concurred with the contract officer's decision. The contract officer therefore requested best and final offers from AmeriHealth, Trusted, Care First, and AmeriGroup on August 11th. That same day, MedStar was issued a letter notifying them that they were found non-responsive as their submission contained a non-compliant subcontracting plan based on the CAB's ruling. The contract officer did not award to AmeriGroup and based her decision on factors that they are unable to disclose at this time due to ongoing contract litigation. So the reason I take issue is because the letters that were issued to AmeriHealth and to Care First were issued 9 days after that decision, after the letter was sent to MedStar. And so if it wasn't their intent to do this, it is very odd that that letter went out in such a short period of time after that decision. The second thing is this. After we filed our letter of complaint to HHS, Office of Civil Rights, we in our team and the number of organizations that we partnered with got a series of calls from the mayor's office, series of calls from others. And there was a meeting that took place, and that meeting took place with 2 of the ministers that were part of our group, a representative from MedStar and Director Turnage, at that meeting, there was an offer that was put on the table that MedStar Health would continue to honor the discounted pricing for AmeriHealth and for Care First if we stood down in terms of our outrage and in terms of our outspoken concern about this situation. So I take issue with what Mr. Cook said, because that would not.
I'm going to pause you there, Mr. Lane. I'm going to give Mr. Cook an opportunity to respond briefly, but then we're not going to do the back and forth.
Absolutely. And I will answer your question that you initially asked.
I appreciate that.
Yeah. Thank you, Chairman White. And I do think it's unfortunate that we're involved in this back and forth. That statement that was just made by Mr. Lane, I do not believe to be true. Now, I was not at such a meeting. I don't know anybody from MedStar who was at such a meeting. So I do not believe such a meeting happened. But if Mr. Ambrose Lane can send me, and I'm happy to give him my email address, he can email me the facts, the dates, times, and personages attending that meeting. I will investigate, but I do not believe that meeting happened.
Okay, thank you. And the record for the hearing will remain open past today. So if additional information needs to be submitted for this, we will be happy to receive it. So Mr. Lane, back to the question of what the council should have done in September. What are your thoughts on that?
So the council's decision was a difficult decision. There's no question about it. It really had to decide whether or not to allow people that were currently on MedStar Family Choice plan to continue that plan. And the council's ultimate decision was to award a 9-month contract in order for them to continue on that plan, knowing that a new procurement was going to take place. And at the end of that procurement, there is a possibility that MedStar Family Choice was not chosen, which means that those MedStar Family Plan Choice members would have to move to another MCO, move to another managed care. That would have been difficult in any situation. And so the council's choice would have been either to say, okay, we'll give a 3-month contract to MedStar Family Choice, and they will end at the end of December, and those residents would be moved, as happened almost 2 years ago now. There was a move of approximately 65,000 residents. So the possibilities were that they would have to move twice if the council decided to do that. So that was a difficult choice. My lack of support for that decision to award the 9-month contract was not based on trying to minimize the number of potential changes that residents will go through in moving from one MCO to another MCO. My opposition to it was that there should have been adjoining legislation or concurrent legislation that would protect residents from this situation happening again. And so in my testimony, I mentioned a couple of different ways to be able to do that. The first was, we've already had the discussion about universal contracting. There should have been universal contracting, and it still needs to come from the council, not from healthcare finance. The second thing is that the council really does need to look at a cost control board similar to what Maryland has. Then when it comes to the issue of pricing, I would say, in my view, that MedStar Health has the advantage in terms of contract negotiations with managed care organizations, because they can simply say, no, we don't agree. And there is no arbitration process to look at what the two sides are offering and determine what is in the middle and fair to both. A contract a cost control board or a cost control council would be able to do that and set the prices that is fair to both the hospitals and the managed care organizations.
Let me ask
Yes.
a quick question, because I have a lot more questions, so I got to make sure we're moving through.
Yes.
And so I'm going to ask everybody to be brief. But you know, I can't say that I fully know why the district aims for 3 MCO providers. It could be argued that having more providers would give sort of a smaller, more manageable population to each. I want to start with you, Mr. Lane, just very briefly. What are your thoughts on us having more than 3 MCO providers?
Well, coming out of healthcare finance, they determined that because of the size of the Medicaid recipients, the number of Medicaid recipients, that 3 contracts is adequate to be able to manage those sizes. But we've seen the disparities in the numbers of care plans through the MCOs, and you have a disparity in terms of how many AmeriHealth has versus how many MedStar Family Choice has. So well over 100,000 people versus just 65,000 people. So there's disparities in that sense, and it's at a disadvantage to AmeriHealth. So having more might be of advantage, but certainly, given the numbers, it should probably be somewhere between 2 and 4.
Mr. Jordan, what do you think?
We've seen the same analysis from the Department of Healthcare Finance. Given our national experience, we have seen similar markets that have had 4, so it is doable. But we have seen the analysis and the issues the Department of Healthcare Finance has. I trust the agency, but we do know there are other markets with similar demographics that do have 4.
Okay. Mr. Cook, does MedStar have a position on this?
Well, position, I think that it's driven by the size of the Medicaid population, the 250,000 population. Sort of the analysis of Department of Healthcare Finance is consistent with what CMS says about how you ought to divide that up. The challenge is that the district and the providers don't get to tell citizens where to go except in extreme situations. So if the enrollees choose MCO A over MCO B, you're going to have a disproportion. So that's part of why you might want to limit it in a market this size to 3 vendors, because if the number gets too small, it becomes economically unfeasible, and then you have a bunch of people who are in a program that doesn't really work for them.
Okay. Mr. Jordan, the district now has universal contracting in its MCO contracts. Is that right?
In a sense, yes. And remember, universal contracting is actually a twofold strategy. It's in our contract, an MCO contract, you have to contract with all the critical providers. That's the acute care hospitals and the federally qualified health centers. There's a separate piece that's not in the MCO contract that is in the district's provider agreement with each hospital that says something similar. So it's being enforced on the contractual side, but we haven't seen it really being enforced on the provider agreement side with the hospitals. So the concept exists, but it's not being enforced. So you end up in a situation where one person has maybe more leverage than maybe an MCO because it's not law or it's not in a contract that's going to be enforced.
And council member, one of the things that I suggested earlier was that one thing that could happen is for the council to look at the certificate of need, because every hospital has to have a certificate of need, has to renew their certificate of need. And one of the things that the council can do is make contracting mandatory in order to get your renewal or in order to receive your certificate of need. If it does that, it does bypass some of the legal implications of trying to do mandatory contracting, which is a little bit more complicated in terms of the legal sense.
Mr. Jordan, when we didn't not too long ago have universal contracting, what was the impact on AmeriGroup?
So when we didn't have universal contracting, when we entered into the market in 2017, we inherited the incumbent, which was MedStar Family Choices members. I think we had roughly about 60,000. And because we did not have a contract with MedStar, even though we tried and we would continue to try ad nauseum, we lost a bulk of those members and they went to AmeriHealth Caritas, who was the only MCO at the time that had a contract. So we lost about 15,000 members. I believe Trusted lost members. And we started to see that adverse selection that impacted the financial health of AmeriHealth and impacted the membership of both Trusted and AmeriGroup.
Okay. And AmeriGroup has never been able to establish a contract with MedStar?
We had a continuity of care agreement, an LOA, with existing members since we were taking MedStar members, and a lot of them were seeing MedStar providers. We had a letter of agreement with them so that we can continue continuity of care at a negotiated rate. But a wider continuity of care agreement, we did not have one.
Okay. And so how is the federal government requires MCOs to have adequate access to hospitals? I think the chairman mentioned this in his statement. How has AmeriGroup met that requirement in the past?
So at a very high level, it has to do with network adequacy and geo access, making sure your members have, they don't have to go far, 50 miles or so, and I'm just throwing out random numbers, to have access to a hospital. When we were in market, we had an adequate network. All of our members received care from any facility that we were under network with. They could go to MedStar through the emergency room, even though we would like to have a contract with them. But network adequacy, we met because all of our members were able to have adequate care, deliver birth, and we had a specialty network through GW at the time.
Okay. One concern I had, the chairman raised it previously, after the solicitation in 2020, my understanding is that AmeriGroup had some difficulty getting a debriefing, but that has now happened. Is that right?
Yeah, right after it was announced, we had reached out to the contracting officer to request a debrief to see what they saw were material weaknesses. We were initially denied and told that the language that the council had passed said, notwithstanding, therefore we didn't have any rights to a debrief and we wouldn't be receiving one. We made some calls. We did a lot to try to get a debrief, and then a few days later, through some, I don't know what happened, but a few days later we got an 8-page debrief, and I also attached that with my testimony, so the committee has it.
And if you could change the next procurement practice to avoid sort of some of the pitfalls that we've seen this time, what would you recommend that we do differently?
So as I spoke to in my testimony, it really comes down to, do we want to do universal contracting or not? I think Mr. Lane talked about other reforms that can happen, and I think that's separate and apart. But we have a system, and I think every member of the council who spoke today, we see a split where one side has more leverage than another. Either we have to get rid of that and go back to where we were, or we have to make sure it's a balanced field for everyone. I can tell you from 2017 to now, we have reached out many times with every provider in the district, and we have almost every provider but MedStar, and we've not been able to engage in a negotiation. Sight unseen, and I may get trouble for this later, I would more than likely be happy to sign a deal that AmeriHealth had with MedStar without seeing it. We are committed to operating in the district. We are committed to improving health outcomes for the residents of the District of Columbia. And, we're willing to move heaven and earth to make sure that happens. But we have to have, I think, as Mr. Cook said, it takes two to tango. We're here, we're able, but without any mechanism to bring a provider or vertically integrated provider who's also a competitor to the table, or a referee to decide what's fair, it'll never be fair. And we'll be in a procurement where only the existing MCOs who are in the market right now have an opportunity to win, because they're the only ones with contracts.
Yeah. And so, I'm concerned about that. If you say that it's almost certain that you would accept the terms that another entity has reached with MedStar, then it makes me really curious about what's going on. I don't know how appropriate it would be for me to push that too hard during a public hearing. But I do want to note the concern there. I don't know what's going on here, but it's concerning because we are best served as a city. The city is best served. Our residents are best served if there's a competitive market, and we we have to make sure we do everything necessary to preserve the competitive nature of that market. So I'm not entirely sure what's going on there, and we may have to dig into this outside of a public hearing, but it is concerning because I still, no one in the public, no one outside of these entities, maybe an agency, I don't know, but we don't know why MedStar and AmeriGroup and others can't reach agreements. Mr.
White.
And Mr.
Yeah.
Chairman, I just want to add one quick thing to what you said. We operate in Virginia and Maryland, and we also have contract with MedStar in Maryland. So we can work together. It's proven just in our regional neighbors in Maryland. It's just the system that I talked about of universal contracting and the procurement that's standing in the way of free and fair procurement and negotiations.
Mr. Chairman, I think
Mr.
that.
I'm
White,
sorry, Mr. Cook was going to say something, and I'll turn to you.
I'm sorry.
Yeah, Mr. White, what I can say is there are a number of issues that get negotiated in MCO contracts and in provider agreements. So like I said earlier, it's complicated and it takes two to agree. But what I want to also be clear about is that MedStar never asked for this universal contracting requirement. This is something that was imposed on the system by the district government. It is not a request that MedStar ever made. So if the district decides to do something different, that's the district's decision, not a requirement, not a demand from MedStar. So I want to be clear. MedStar seems to be taking a lot of blame in this hearing, and I know that's not your intent, but we want to be clear that this is not a creation of MedStar. This is not a requirement of MedStar. And if the district chooses to operate a different way, we'll have to deal with that environment just as we deal with the current environment.
Okay. Mr. Cook,
Mr. Chairman, I just wanted to make a comment because the latest conversation is why I am emphasizing the need for a neutral arbitrator. It would solve the problem, and a neutral arbitrator would be able to provide the pricing and the discount pricing that is fair to both sides. It would be able to oversee the implementation of that, and it would take any advantages from either side out. That is why I made the suggestions that I've made. I have no dog in this fight. It is not my role to choose which MCO comes to the district or which hospitals they need to deal with. That's not my role. My role is to make sure that the system is fair for the residents of the District of Columbia, and that's the vantage point that I come from.
did you testify that Maryland has a neutral arbitrator?
Well, they do through the Cost Control Board, because they are the ones that determine the pricing between hospitals and managed care organizations.
Okay. Mr. Cook, do you have thoughts on that, or Mr. Jordan?
Excuse me, I think, I guess I disagree with Mr. Lane's characterization of what the Maryland board does.
Mm-hmm.
That board regulates the price, but not the cost. And there's a difference between price and cost. So
Sure.
when you talk about what an agency's costs are, what an entity's costs are, that's a different issue. And that's part of what we're wrestling about here today. But that's not what the Maryland body does. So again, I don't get to say that Mr. Lane's solution is inappropriate. I just think it doesn't do quite what he said it does, and maybe the district one, if it gets created, can do that, but the Maryland one doesn't do that.
Okay. Libby, Mr. Jordan, if you have something to add on that point, I'll take it. If not, I'm going to move to a different issue.
Just, I'd probably be more aligned with Mr. Cook. I think the district needs to take a comprehensive approach, including the very smart people at DHCF, and look at best case scenarios across the district. I know it works well in Maryland, but it may not work well in DC. I don't know. I can't opine on that. But I do think the district needs to really take a holistic approach of how we do Medicaid in the district.
Mr. Cook, turning back to the solicitation, the 2020 solicitation, the CAB order in this case was about a number of OCP errors, not just about, or not even about the timeliness of the submission of the subcontracting plan. But could you describe the communications that MedStar received from OCP about the subcontracting plan prior to submitting its bid?
I think so. We didn't have direct communications with OCP about our subcontracting plan prior to submitting the bid. It was alluded to by Councilman McDuffie that somehow we were given a different set of rules to play by, and we were not. We were not told by OCP to do it this way because you don't have to, because everybody else did. We did what we were asked to do. We provided the documents we were asked to do. And as our proposal went through the portal on the submission date, if OCP believed it was deficient, it would have been kicked out. They did not kick it out. At a point in the process, after July, we were asked to begin a dialogue with OCP about completing a subcontracting plan. And that went back and forth for a while. And ultimately, in December of 2020, the subcontracting plan submitted by MedStar First Choice was approved by both OCP and the Department of Local Small Disadvantaged Business.
Okay.
But during that whole time, nobody said, this is squirrely, you shouldn't do it this way. We did what we were asked to do.
Okay. I believe the notion that MedStar was told by OCP to submit a subcontracting plan later in the process. I believe that notion came from Deputy Mayor Turnage, and so hopefully the government witness, Mr. Shutter, will correct me later if I'm wrong. But I believe in the argument to the council, if I recall correctly, the argument was, well, we can't hold MedStar accountable for this mistake because OCP told them that it was okay to submit the subcontracting plan later in the process.
I can't speak to what Mr. Turner said exactly. I mean, I think we were asked, as I said just a little bit ago, to submit a subcontracting plan, and we did. And that ask was made roughly in July of 2020. At least that's when it began, and it was completed in roughly December of 2020. It was approved rather in 2020. It was completed before that, but it was not approved until December 2020.
So you noted, Mr. Cook, and rightfully so, the MedStar has gotten beaten up on this. Your testimony, I do understand, is that the sort of the communications sent in, I think it was August rather, was not, hey, we're, the other MCO providers cannot use our provider network and facilities if we're not part of the MCO contract, but rather that this was the normal course for rebidding, and that the time had come for rebidding. Is that right?
For resetting.
Okay. So could you, in addition to the letters that you sent for August, that you sent to the providers, could you send previous letters that had been sent, so that because I think it would help to underscore MedStar's point that, hey, this is what we do in normal course. So when those in prior years, when it was time to reset, if you could send us sort of the similar letters, then we can say, okay, clearly this was MedStar's pattern in practice here.
I will certainly endeavor to do that. I don't happen to have those with me. I know, for example, CareFirst is a company that last year had $10 billion in revenue, much more than MedStar. AmeriHealth is a company that had $21.8 billion in revenue last year, much more than MedStar. Those are companies that are not going to be bullied by MedStar because they have significant economic power beyond MedStar's. So these back and forths happen, and I will endeavor to get those documents that are similar. They may not be literally identical, but we will be similar agreements similar letters rather that reset rates in past years.
No, I appreciate it. I think it would help provide a lot of kind of clarity on MedStar's position, and I think would make folks feel a lot better about what we saw and would see it. I think ultimately through the lens that you articulated. So finally, Mr. Cook, turning back to the big picture, do you have any recommendations on how we can improve the procurement process going forward so that we don't end up with sort of the same type of mess that we've seen in the past?
Well, Mr. White, as you know, I've sort of been around district government for a little bit. And this problem that occurred in this procurement is not unique to the MCO procurement. There have been lapses, if you will, by OCP for many procurements, large and small, where we've had some less than perfect compliance. So I think that one of the things that the council needs to look at is procurement in a big picture sense across the board. This procurement is important, obviously, because it's got a large dollar volume and the impact on so many of our citizens. But the dollars are large because we have 40% of our population that is Medicaid eligible, and healthcare is expensive in the United States. So the number is going to be huge. But I would suggest and urge the council not to lose sight of procurement in the big picture sense for people who deal with $100,000 contracts, $200,000 contracts, whose those monies represent the lifeblood of their business. And if the procurements are screwed up, their businesses are wrecked. So I think that I've read the director of OCP's testimony. I think it lays out a good methodology for getting to a successful, efficient procurement for MCO contracts. I'd like to see that done across the board for procurements generally in the government. So I'm pretty comfortable with what they have used. They've got a new tool they've gotten to help them do the evaluations. And I think, without being too smart alecky, I think you and the members of the council are going to be watching them like a hawk, and you're going to make sure that they do comply and they do produce a result that the city can be proud of. So I'm pretty comfortable with what OCP is recommending.
I appreciate it. Mr. Jordan, in your testimony, you mentioned with regard to last procurement several times your technical score. And so it leads me to kind of wonder, is there another sort of scoring factors? So you were making the argument that, our technical score was, equal to one of the entities that was awarded a contract. Are there other elements of the selection where AmeriGroup was not on par with the folks that were selected?
Well, in the document I sent you, regardless of what it was, we would have been top three. But there's the technical score, there's the cost, which we scored quite competitively on. And then there's the section for CBE status. We're not a CBE, but under, maybe a loophole in the law, which I think the council has changed, Care First Trusted has considered to be a CBE. But on technical and on cost, we were quite competitive and higher than folks that may have been selected to be an awardee for this contract.
Finally, Mr. Lane, you have a final comment?
Yes, I think transparency is also important. And I think that any final results of the scoring of contracts should be publicly released. I think it's important to reassure the public that Office of Contract and Procurements has chosen the top three or the best contracts for the city.
Mm-hmm.
And that should be public information.
Okay. Well, I want to thank all three of you for testifying today. This is a difficult and complex issue, and we want to make sure we get as much clarity, both to answer the questions and concerns that residents and officials have about the previous procurement and various issues that we saw in that process, but also to make sure we're doing everything that we can to tighten up the procurement in the future so that we at least see fewer of these types of issues. So I do want to thank you all for being with us for this hearing today.
Thank you,
Thank you,
sir.
Mr. Chairman.
Thank you.
Thank you, Mr. Chairman.
We're going to move now to our government witness, and I'd like to call up Chief Procurement Officer George Shutter.
Good afternoon, Chairman.
Good morning, Chief Shutter. Almost afternoon.
Almost afternoon.
Yes, indeed. We were just together yesterday, so welcome back. As you know, it is the practice of this committee to put our government witnesses under oath, so I'll ask you to raise your right hand. Do you swear or affirm under penalty of perjury that the testimony you are about to provide to the Committee on Government Operations and Facilities is the truth, the whole truth, and nothing but the truth?
I do.
Thank you very much. You can begin your testimony.
Thank you, Chairman. Good morning, Chairman White and the Committee of Government Operations and Facilities. I'm George Shutter, and Chief Procurement Officer of the District of Columbia and the Director of the Office of Contracting and Procurement. First, I'd like to thank you for allowing me the opportunity to provide testimony on the procurement of the Medicaid Managed Care Organization contracts and answer any questions you may have. As you are aware, the MCO contracts represent some of the most significant contracts solicited and executed by the Office of Contracting and Procurement and the government of the District of Columbia. These contracts impact the well-being of some of our most vulnerable residents. As the CPO of the district, I'm deeply aware of the significance of OCP's role in completing a seamless, timely, and legally sound procurement of the MCO contracts. OCP has always worked closely with the council, with the mayor, and the attorney general in following the regulations and best practices during the approval process of MCO contracts. My testimony today before the committee will detail the chronology of the procurement of the MCO contracts, as well as the steps OCP is taking now and in the future to ensure these vital healthcare services for our residents continue uninterrupted. Before I begin, it's important to remind Council that one of the procurements discussed today is the subject of ongoing litigation. Thus, I'm limited in what I may speak to. Likewise, because it has been determined that the new solicitation of the MCO is required due to the recent addition of behavioral healthcare, I'm unable to speak in detail the new solicitation as it is an active procurement. Regarding the solicitation, on behalf of the Department of Healthcare Finance on January 10th, 2020, OCP issued a request for proposal in the open market seeking up to 3 contractors to provide healthcare and pharmacy services for the district's managed care organization program. When the solicitation closed on February 20th, 2020, OCP received 7 timely proposals. Accordingly, OCP organized and convened a technical evaluation panel to evaluate the timely proposals. As with all TEPs, members received instructions on how the evaluation process is conducted and were advised that all evaluations must be completed individually without the help of other TEP members or outside persons. Individual evaluations were completed by the TEP members, who then met and provided a consensus report to the contracting officer. After reviewing the TEP consensus reports, the CO independently evaluated the technical and price proposals and documented her findings in a pre-negotiated business clearance memorandum. On May 19, 2020, the contracting officer executed the determinations and findings for the proposal in the competitive range, finding 4 offerors to be in the competitive range. The CO issued requests for best and final offers letters to those 4 offerors, which were AmeriGroup District of Columbia Incorporated, AmeriGroup, AmeriHealth Caritas District of Columbia, AmeriHealth, Trusted Health Plan District of Columbia, DBA Care First Blue Cross Blue Shield Community Health Plan District of Columbia, Trusted Care First, and MedStar Family Choice, MedStar. OCP received all BAFO responses from the offerors in the competitive range by May 20th, 2020. The same day, the CO convened the TEP to evaluate BAFOs. OCP required BAFOs so that the CO would have the opportunity to negotiate with each of the offerors to improve their proposals and seek a comprehensive and valuable solution for the districts and its residents. The CO conducted her final review and determined to award 3 contracts to AmeriHealth, Trusted Care First, and MedStar. On June 1st, 2020, the CO sent 3 proposed contracts to the projected awardees for signature before sending the council packages for approval. On July 9th, the CO issued a letter to AmeriGroup indicating they were an unsuccessful offeror. DHCF posted an announcement on its website on July 16, 2020, stating the district's intent to award the MedStar managed care contracts to AmeriHealth, Trusted Care First, and MedStar. On the same day, AmeriGroup filed a protest with the contract's appeals board. At the request of AmeriGroup, OCP held post-award debriefing on July 17, 2020. Additionally, on July 17th, the executive branch transmitted the packages for the proposed contracts to the council for review and approval. On July 29th, Chairman Mendelson, along with council members White and Duffy, filed a notice of intent to disapprove resolution, extending the council's review of the proposed contracts by 35 days of the initial submission of the contracts to council. The council deemed approved the transmitted contracts on September 3rd, 2020. Meanwhile, on August 20th, 2020, the CAB issued a decision in the protest of Conduent State Healthcare, citing the Small and Certified Business Enterprise Development Assistance Act of 2005 as requiring all proposals to contain a compliant subcontracting plan upon submission to the district in order to be found responsive. While the district can award procurements based on initial proposals, the negotiation component of RFP process gives the CO the ability to advise offerors on the shortcomings of their proposals and for those offerors to improve their proposals through a BAFO process, best and final offer process, allowing an updated proposal to be submitted based on the shortcomings. Prior to the Conduent ruling, this included remedying deficiencies and errors in the subcontracting plan. The district utilized this negotiation process in competitive sealed proposals for over 15 years. And the negotiation factor is standard practice as referenced in the American Bar Association's 2000 Model Procurement Code. The Conduent ruling changed the negotiation process for the district so that no matter the prime contractor, CBE or otherwise, any deficiency or errors in the subcontracting plan upon submission would disqualify their proposal from review, thus completely removing the prime contractor and its subcontractors from the competition. The district filed a motion for reconsideration to clarify the opinion and limited stay on September 4th, 2020, requesting clarification of which solicitations the Conduent decisions applied to, and a limited stay of the opinion until January 15th, 2021, in order to maintain continuity in procurement practice while having that opportunity to seek legislative clarity on the issues presented. The CAB denied this motion on October 5th, 2020. On December 1st, 2020, the CAB sustained AmeriGroup's protest, ordering the district to reevaluate the competitive range offers proposals before any option years of the existing contracts could be exercised. The CAB issued its opinion, citing OCP's evaluation of the offeror's proposals as unreasonable, while noting that it would be prudent for the district to be mindful of protesters' allegations that were not addressed by the opinion. The district thereafter filed a motion to reconsider to clarify the board's December 1st opinion, requesting specification on the remaining allegations the district must consider in the reevaluation of the competitive range offeror's proposals. OCP moved to reassess the proposals within the competitive range in alignment with the CAB's December 1st decision. To cite implications stemming from the CAB's ruling to Conduent, OCP reevaluated all 4 proposals in the competitive range, including the proposal submitted by MedStar, as there were ongoing legislative efforts by both council and the executive branch that may have impacted the reevaluation. OCP began this process in earnest in March 3rd, 2021. OCP employed a commercial source selection facilitation tool to assist in the TEP members in completing a cohesive, uniform evaluation of each proposal. AmeriHealth's proposal was first to be evaluated. The TEP subsequently evaluated Care First proposal on May 13th, and AmeriGroup's and MedStar's proposals on June 25th. On May 28th, 2021, Chairman Mendelson, Council members R. White and McDuffie introduced Bill 24-0263, the Fidelity and Compliance of Contracting and Procurement Emergency Amendment Act of 2021, requiring OCP to complete the reevaluation of proposals in the competitive range by June 30th, 21, and requiring the district to procure services from no fewer than 3 MCOs. The council passed this bill, however, the mayor vetoed it on July 29th, 2021. The CO completed her independent assessment on July 8th, following the final TEP consensus meeting. Upon completion of the reevaluation, as instructed by the CAB, it was found that there are no change in the ultimate rankings of offerors in the competitive range. A procurement review committee meeting was held on July 19th to review the CO's independent assessment, including a discussion of the final items that should be requested of the offerors through the anticipated final BAFO. One example of the final items to be requested was clarification is needed whether the organizational structure and staffing plans remain valid for all offerors. The Procurement Review Committee reviewed and concurred with the contracting officer's decision, and the contracting officer therefore requested those best and final offers from AmeriHealth, Trusted, Care First, and AmeriGroup on August 11th. That same day, MedStar was issued a letter notifying them that they were found non-responsive as their submission contained a non-compliant subcontracting plan based on the CAB's ruling in Conduit. OCP received all 3 BAFOs from the remaining offerors by August 18th, 2021. The CO did not award to AmeriGroup and based her decision on factors we're unable to disclose due to ongoing litigation. On August 20th, 2021, DHCF notified members of the council that MedStar planned to end its preferential pricing agreement with Trusted, Care First, and AmeriHealth. DHCF noted that such a move would result in the loss of healthcare services to many district residents relying on the district's Medicaid program. On September 1st, the mayor issued Mayor's Order 2021-105, declaring a public emergency, allowing the district to enter into necessary contracts for the provision of healthcare services for residents participating in the Medicaid and DC Healthcare Alliance programs. That same day, the executive submitted partial option exercises pursuant to the emergency declaration and the Mayor's Order 21-105. On September 10th, Chairman Mendelson and Council members McDuffie, Silverman, and R. White signed a notice of intent of disapproval and extended the process for approving these contracts for 45 days. To prevent a disruption in healthcare services, OCP executed 3 contracts with AmeriHealth, Trusted, Care First, and MedStar on September 16th. In discussions with the executive branch, the legislative branch recommended a different vehicle for the MedStar contract. On October 1st, the district submitted to the council a new contract for MedStar and a letter describing the actions the executive had taken. In a memo to council dated September 30th, 2021, Chairman Mendelson requested consideration of emergency legislation that would provide a 9-month stopgap for the current MCO procurement to proceed by retaining the 2 executed contracts with AmeriHealth and Trusted, Care First, and executing a contract not governed by the PPRA with MedStar, avoiding a disruption in critical healthcare services for the district's most vulnerable residents. Chairman Mendelson asserted that a period of 9 months would provide a solid foundation for agreements to be finalized and provide adequate time for new solicitation to be completed. The council passed emergency legislation approving the contracts per the Contracts with Managed Care Organization for the Provision of Healthcare Services to District Residents Approval and Authorization Emergency Act of 2021, effective October 1st. This legislation was approved by the council on October 5th and signed by the mayor on October 6th. Moving forward, Looking ahead, the district is taking a new whole health approach in providing critical healthcare services to the residents who depend on the district's Medicaid program. Beginning with a forthcoming solicitation, the district seeks to incorporate a full suite of behavioral health services into the program. As this will result in a material change to the scope of work, the district must create a new solicitation, which is standard practice. In the meantime, the district will continue to utilize the executed contracts to provide health services to district residents. Again, while I am limited on what I can share regarding the new solicitation, I would like to share that the multitude of steps OCP is taking to ensure the crucial delivery of healthcare services to district residents is not delayed by any interruptions in the procurement process. The new solicitation process will feature increasing monitoring and oversight. OCP has selected a contracting officer that has convened an integrated procurement team that meets weekly. Additionally, the procurement team is doing all they can to prevent any issues that may cause delays, such as working with our colleagues at the Department of Small and Local Business Development to ensure CBE participation. This new approach, including the formation of the IPT, is supported by DHCF, the Department of Behavioral Health, and the Office of the City Administrator. The IPT will engage with those respective agencies, the City Administrator, myself, as the solicitation, evaluation, and award process progress. Further, to ensure the behavioral health core capabilities are fully encompassed in the MCO solicitation, OCP teams that are working on the new solicitation will receive support from behavioral health subject matter experts. OCP is also taking new steps to increase awareness in procurement and inform would-be offerers of the requirement of the upcoming solicitation, as law and regulations permit. One such example is our Medicaid Managed Care Organization Industry Day, which we held yesterday on Thursday, August 28th, where we discussed the solicitation with our industry partners. This event further provided an opportunity for prime contractors, subcontractors, and providers to network before the solicitation is released. As you may be aware, the procurement timeline for the new solicitation is condensed. The district aims to have solicitations out before Thanksgiving with the intention of sending a negotiated contract to council for approval by June 2022. This timeline will provide adequate time for review by the Center of Medicare and Medicaid Services as necessary, followed by a 3-month implementation period ending by October. I hope my testimony today has demonstrated the diligent work of OCP and our team of procurement professionals to ensure that the services provided by the district's Medicaid program continue uninterrupted. In all MCO procurements, past and present, my objective has been to make certain that they fall in line with the law, including OCP's mission to procure quality goods and services fairly, impartially, and transparently in a timely manner and at a reasonable cost. Because of the significant impact the Medicaid program has on the health and well-being of our district residents, I've always been acutely aware of the tremendous responsibility OCP carries in seeing that the MCO contracts are approved and implemented in a manner rooted in the law and best practices. I remain committed to working closely with the council, the mayor, the attorney general at every step of these MCO contracts approval process to ensure the new contracts are executed with integrity and transparency. I want to thank Mayor Bowser, City Administrator Donahue, and Assistant City Administrator Parker for their continued leadership and support through this procurement process. I thank you, Chairman White, and the members of the Committee on Government Operations and Facilities for the opportunity to testify and your ongoing support and oversight. This concludes my prepared testimony, and I'm happy to answer any questions that you may have.
Thank you very much, Chief Shutter. So let me start with something that came up at the end of the last panel, as I asked the two of the panelists what they would recommend for improving this solicitation going forward. And representative from MedStar, which is by far one of the largest contractors with the city, said that issues with procurement are not isolated to this MCO contract, but really the issues exist with large and small solicitations and procurements. I'd like to get your thoughts on that because I mean, clearly, in my opinion, that this procurement it showed some very concerning problems. But you know, to have a large contractor say they exist in large and small procurements is very concerning. So, what are your thoughts on that briefly?
My thoughts, Chairman, is that as the CPO and OCP, we execute the contracts of the District of Columbia under the laws and the regulations of the district. These MCO contracts are certainly very complicated and highly nuanced, and we filed the laws in effect at the time of the decisions that the contracting officer makes those decisions. I'm very proud of our agency and the results of the contracts that we've executed. We certainly keep in mind the 250,000 beneficiaries that are at risk here, and have not had a day of loss of services with them, which is of utmost importance, certainly.
So, I mean, to this point, and I'm going to push a little bit. So, your testimony, you speaking about the conduit case, cited OCP's practice of using a procurement model from the American Bar Association's 2000 Model Procurement Code, but that's in conflict with DC law. And so we, I think, clearly have not followed procurement law. And your testimony today says that's okay. There was a reason for it. And so, you know, and this is, you know, in response to Mr. Cook's statement. So how do we have confidence that our procurement is happening in the way that it should? You know, if you're even today testifying, well, you know, with respect to the conduit case, we followed something else different than DC law. How should we square that?
My testimony, Chairman, and my comment consistently has been that I, as the CPO, and my contracting officers follow the law and follow the regulations. And that's what we do, and that's what we continue to do. Regarding the conduit decision, I would say again that my contracting officers, the contracting attorneys, myself, the attorney generals, the mayors, the council of the past 15 years have all concurred with the process that the district has followed, which I believe has been in line with the law. And the CAB has made a ruling that interprets that law in a different way that has been followed by contracting officers and contracting attorneys and attorney generals and everybody in public service for some time. My comment is that the practice that has been followed for 15 years is aligned with best practice and is aligned with what the American Bar Association concurs with. So we do follow the law, Chairman, and we continue to follow the law. The law since the conduit ruling in effect has changed because the CAB has a different ruling on the interpretation of the law that every contracting officer and every attorney in the district has made for the last 15 years. So we do continue to follow the law, and I will continue to follow the law.
All right. I mean, that's concerning to me. I can't give you the citation offhand because it's been a couple of months since I read it, but I have read the law with respect to when subcontracting plans are supposed to be submitted. And it's not a complex thing that's open to a lot of interpretations. It says very clearly, but your argument is, I believe, that best practice is different than DC law. So in this case, please go ahead.
What I would say is that the CAB interpretation is that both invitation for bids and request for proposals, that at the initial submission is when a proposal submitted by industry needs to be is considered the proposal submitted. The law is interpreted for request for proposals has been that the best and final proposal received is in fact the proposal that's received by the district and the proposal that is ensured to be legally compliant prior to awarding a contract. So the interpretation was different than not only what the PPRA allows, the regulations allow, and what is the practice internationally. So it's a different interpretation of the law, and the district and district contracting officers very simply considered best and final offers received as the proposals. It is actually very straightforward, Chairman.
Now, do you have the language on hand or easily accessible? Is what DC law says with regard to the appropriate timing of subcontracting plans?
The law is, I do not have that in front of me, Chairman.
Okay. I'll try to grab it because it would help, I think, in this conversation. With respect to going forward, OCP is following the conduit decision.
Absolutely, Chairman.
Okay. All right. So the legal language, the subcontracting plan required by paragraph 2 of this subsection shall be provided before the district accepts the submission of the bid or proposal. And so your argument is that bid or proposal is open to interpretation?
No, not at all. My opinion, my reflection of that is that a bid is received and you have a public opening. You open the bid when you receive it. Everything that's submitted at the time of receipt is what the government considers. In a request for proposal process, the bid that is the proposal that is considered is the final proposal that is received, which may or may not be the result of a best and final offer process. So the proposal that the district has considered all along, which is best practice, I would agree, I would say again, is the final proposal that is submitted. That allows the district to understand, to read proposals. And if the district chooses, the district can award a contract on initial proposals. But the district has an opportunity through a request for proposal process to read proposals and to say, here are errors in the proposals, or here are some weaknesses in the proposals. And you have an opportunity to resubmit those proposals rather than throwing them out. So if you're thinking about buying a car, rather than throwing 3 out and keeping 1 and you're negotiating with 1, you're telling 4 entities how they can improve their proposals. And that final proposal that comes in is the final proposal that is considered. So instead of throwing them out because of an initial proposal that is received, which we could do, you increase your competition, you work to get the most innovative thoughts that you can from a proposer, and you consider those proposals as those final proposals that are received as the proposals that you evaluate. That allows for competition, it allows for better quality and lower pricing, frankly, for our residents.
Is it within the agency's authority to codify what you're suggesting in regulations through the administrative law process?
I would say that anything I could address in regulations here, Chairman, would really be pre-decisional and deliberative. So I would need more reflection to respond to you there, Chairman.
Okay. And another question from your testimony, OCP began the reevaluation process in March of 2021, that's right?
Yes, Chairman.
Okay. And it took a few months to do that?
Well, Chairman, there was the protest and there was some deliberation between our attorneys and the CAB. that took place. The reevaluations began in March and were completed in the July timeframe.
The reevaluation. Okay, so it took about 4 months.
Yes, Chairman.
Okay.
That's correct.
All right. And in the reevaluation, the three bidders that prevailed in the original evaluation were the same three that prevailed in the reevaluation. Is that right?
The reevaluation took place with the 4 competitors in the competitive range. That was what the CAB required, that we reevaluate those competitors in the competitive range, and that is what took place.
Okay.
And the results of so the CAB advised us in 3 areas to reevaluate specifically. The results of that reevaluation did not change the results of the ultimate scoring, Chairman.
Okay. The scores didn't change at all, or just the ranking of each bidder didn't change?
The ranking did not change.
Oh, okay.
And the scoring is allowed to be seen by the public is in the redacted version of the business clearance memorandum that the Contracts Appeals Board has posted.
Okay. It is heavily redacted, so it hasn't been incredibly helpful for me. But how does the conduit decision impact the reevaluation?
So ultimately, Chairman, the CAB required the district to reevaluate the contract or the competitive range prior to awarding new option periods. And that had to be done by September 30th before we executed the new option period. So the conduit hearing ultimately, or the conduit ruling ultimately removed MedStar from the evaluations as because of the conduit ruling and the subcontracting plan that was initially submitted. Even though the final subcontracting plan submitted in the proposal was appropriate and legally sufficient, and the contract that was awarded had a fully compliant subcontracting plan.
I mean, it sounds like you're saying that MedStar was not compliant, but previously you said that the rankings didn't change. So how can both of those be true?
So the rankings didn't change. However, MedStar was not considered for award because of the subcontracting plan requirement of the conduit case.
Okay, so a bidder on a contract can score the highest even if their response to the solicitation is not compliant with the law?
No, Chairman. Under the current law, under the current conduit case, which has the effect of law, if a proposal is received by the district, whether that prime contractor that submits the proposal is a CBE or non-CBE, if their subcontracting plan is not fully compliant under the terms of the law, that proposal will not be considered for award. In this case, the proposals received in the initial awards were prior to the conduit ruling taking effect. And so therefore, in this case, and during this past year, as there have been various legislative actions that have taken place that may or may not have affected the ultimate results of the MCOs in specifically regarding the conduit case, my direction to the contracting officer was to score all 4 in the competitive proposal. And when we have the results of legislative actions, we'll make the determination if that contractor remains in or remains out. And ultimately, the MedStar was not considered for award because of the conduit rule.
So the CAB's decision in this issue was issued in December of, I guess it would have been 2020. But the reevaluation that they ordered in December of 2020 didn't start until March, so about 3 months later. Why is that?
Well, when the protest was received by the district, there are back and forths between, and then as in this case, between the Attorney General and the protester on the issues that the CAB and the direction of the CAB, so that did take a number of months to also come to fruition. Ultimately, the questions that the district had to the CAB were not responded to, and so there was some back and forth, Chairman, prior that would affect how the scoring would take place and how the reevaluations would take place. So they began in March.
What type of back and forth? What would be the nature of those types of things? Because, you know, CAB had issued an order, and so then what would be a relevant conversation with America or others?
Yeah, for example, Chairman, the CAB issued it. The issuance from the CAB had, I believe, 3 specific items for the district to review, but then said we should also consider other things. And so we wanted to understand, prior to completing the reevaluation, what are those other things? So, for example, that was part of the back and forth between our attorneys and the Attorney General and the CAB.
Okay. Did OCP advise MedStar as to when they could or should submit their subcontracting plan?
OCP advised all offerors in our solicitation the requirements for a subcontracting plan. And those did go out, as is typical in any, well, is typical in many requests for proposals. You'll have, once you have the solicitation on the street, there may be questions from industry. We'll receive those questions. The contracting officer will then take those questions and respond to them and actually do an amendment to the solicitation, responding to all offerors on the response to the question, so that we keep an even playing field. I have asked the contracting officer specifically through my chain of command if there's any further deliberation or discussions with MedStar regarding the subcontracting plan, and the answer to that is no.
What was the extent of the communication between the administration and Care First?
It would be the same, Chairman. We communicate with industry via solicitation and amendments to the solicitation to answer questions. And realize, Chairman, that this is a procurement sensitive time, right? So when you have a solicitation in the street, the solicitation specifies, if you have questions, this is who you send them to. And there is much regulation in practice around how a contracting officer responds to those questions. And that is what took place here.
Did the administration have discussions with MedStar about MedStar renegotiating its terms with other MCO providers prior to MedStar sending a letter?
Chairman, as I stated before, that the engagement that we have had with all of industry has been through solicitation and through formal question and answering period. So that's my response, Chairman.
I take that as a no.
No, that's correct, Chairman.
Okay. And why did CAB initially let me ask this. Why did the administration lobby the council to keep a private entity in the running for a contract? So the CAB ruling came out, then the request from the administration to the council was for us to pass legislation that would deem MedStar's application as compliant. Why is that appropriate to do that for one entity?
You're referring, Chairman, to the contract that was sent post the declared emergency?
I'm talking about the legislation introduced by Councilmember Gray that was requested by the administration.
And what is your question to me on that, Chairman?
So that legislation, what was requested of the council was for us to pass legislation that would deem MedStar compliant with their offer compliant so that they could be considered. So the question is, why would it be appropriate for the city to deem a non-compliant responder as compliant? Why would that be appropriate here?
Oh, gotcha, Chairman. The contracting officer and myself, we followed the law and the effect of the law at the time of the decisions that we make. Whether the legislative branch or the executive branch puts forth legislation that may or may not affect our contracts, we have to consider those. But I have no response, Chairman, on what actions either the legislative branch or the executive branch takes towards legislation.
Well, I mean, there was a request, though, that has to do with a procurement. There was a request to deem one entity as compliant, even after the CAB said that they were not compliant. Do you believe that that is appropriate for procurement?
It's appropriate, Chairman, for me to follow the effects of the law and the pending litigation or pending legislation or legislation. So I follow the law. I have no opinion on what laws are out there and are approved. I have to follow the law when the law comes into effect. And there were actions on both the executive branch and the legislative branch that were legislative actions that may have affected this. So what legislative actions are taken, that's not my bailiwick. I follow the law, and I follow the law when the law becomes effective. I have no comment on either the executive branch or the legislative branch's motions to change the law. We follow the law as the law is in effect.
But you are here as the designated representative of the executive, and there was a request from the executive for the council to pass this legislation. And so my question is was this an appropriate request?
And my response, Chairman, is that if the law was passed, we would follow the law. The law was not passed.
The law was not passed, but the proposal was put on the table, and gives an indication as to what the city may or may not be willing to do in its procurement process. And the indication is that the city would consider, I'm glad it did not pass, but the city would consider where it wants to override both the law and the CAB. And that does impact the fidelity of our procurement process. It does impact the reputation of the district. And as the representative of the executive, I'm asking how this was appropriate.
And what I'm stating, Chairman, is that I'm a public servant and we follow the law. And in the district, it's 7 votes to change a law. In this process this last year, there have been many pieces of requests to change the law that I have to consider. I have to consider when we're awarding and managing contracts for the District of Columbia and for our residents. I have to consider the industry footprint. I've got to consider the requirement. I've got to consider the laws and the regulations, and I've got to consider the potential laws and regulations that have been put forth and how they would affect it based on when the timing of the decision that takes place. So this is a very nuanced environment. And I can assure you that we follow the law. We monitor the perceived changes in the law that may affect the decisions that we make in our contracts. But there have been many pushes to affect the law in this last year that we have had to be mindful of in the contracting officer decisions that we've made here all along in this very nuanced environment.
I asked a question to the previous panel about the idea of more MCO providers and maybe smaller plans. Perhaps that would be more manageable. What is your take on that?
You know, the district in this past solicitation and Ford, I believe, is the contract requirement is for up to 3 MCOs. There are many factors that the district has to consider, including capacity. So I look at this very much as a district requirement versus industry footprint to get us to the right number and beneficiary or organizations that will serve our beneficiaries.
How does our ratio of patient to provider, MCO contractor, compare with other jurisdictions?
I would defer that to the program chairman.
I don't understand.
I would defer that to the Department of Healthcare Finance. I'm not a programmatic expert on Medicaid or Medicare, sir.
What is the deputy mayor's and DHCF's role in the procurement of these MCO contracts?
Well, the director of the Department of Healthcare Finance is ultimately the program manager, the program owner of the requirement. And in any procurement, in any contract, there are requirements of the program, the client agency, as we've discussed before, Chairman, requirements of the contracting officer, requirements of various agencies in the district, like First Source with DOES, and requirements with even the Attorney General, the attorneys that are part of that. So ultimately, the director of the Department of Healthcare Finance is ultimately the program manager of that. So the program defines the work, the scope of work that is needed for the district, and as well works on source selection criteria to determine the best providers that we would receive for the requirements of the program. So those would be the areas I think that the program focuses in on. You've got contracting and legal that provide the balance of legal sufficiency and best practice when it comes to those functions.
Okay, so the question of how many providers we have is a programmatic question and not a procurement question?
Well, the requirement of up to 3 providers is a programmatic question that receives review from a contracting officer, as well as the attorney general and attorneys there from a legal sufficiency standpoint, that the requirement is not overly restrictive. And so programs develop requirements, contracting officers and in the attorney general, in this case, attorneys review those requirements to ensure that there are many things, including not restrictive, not gold-plated, meaning that the requirement is really bigger than what the government actually needs, or it's not overly restrictive, meaning that
Chief, I'm only talking about the number of providers at this point. I want to stay focused on that for a second so that we get too far into other subject areas. I guess I'm hearing that OCP does not play a role in determining how many providers we have.
What I'm saying specifically, Chairman, is that the requirement of up to 3 MCOs is a requirement, a programmatic requirement that a contracting officer makes a determination that that requirement, like any requirement, is not overly restrictive in the environment based on the requirement, and that there is an attorney general that is looking to see the sufficiency of that.
Okay, the contracting officer is OCP employee, or?
That's correct, Chairman.
Okay.
Contracting officer is a warranted contracting officer that I give a delegation in writing to execute contracts on my behalf.
Okay. So if DHCF said, look, we want up to 5, then that's what OCP would do?
If DHCF said it's up to 5, and our review was that that requirement was not restrictive and not violation in any other aspect of the law, then yes, that would be an adequate requirement.
Okay, so you don't look at best practices. You just look broadly, is it not overly restrictive?
The contracting officer will ensure that the requirement is reasonable.
Okay. Who created the scoring rubric in the 2020 RFP?
Ultimately, DHCF develops under the guidance and work with the contracting officer. The program develops the source selection criteria, and the contracting officer will work with them to ensure that the criteria of source selection is, again, reasonable. So the program develops source selection requirements, and the contracting officer will guide them and ensure that they're reasonable.
Okay, so created by DHCF, reviewed by OCP. Is that right?
Yes, they are developed by the program, and they are approved to be reasonable by the contracting officer.
Your testimony, you said that OCP held a post-award debriefing on July 17th of 2020. Can you explain that process and who was represented?
So a debrief is provided when an offeror requests a debrief when they've been advised that they are not going to receive an award. A debrief may be pre-award or post-award. Pre-award being, the before the award is made, the contracting officer can still debrief and provide a debriefing to an unsuccessful offeror prior to the award being made. So, for example, if contracts are
I follow you on it. So I don't need the example, but I guess, so the July 17, 2020 debriefing, who participated in that?
That would have been the contracting officer and the proposer.
AmeriGroup?
Whoever requested the debriefing, that they would have received it from the contracting officer.
Okay, so when did AmeriGroup receive a debriefing?
I will have to look in the timeline. You're talking about in the initial award, Chairman?
I'm talking about following the July 2020 award.
I believe they, let's see here. The 17th of July is when they received their debriefing.
Okay. Turning to your comments on the failure of OCP to follow the law that, well, your interpretation is different, requiring compliant subcontracting plan at the time of the bid or proposal. You referenced that that your practice was based on the 2000 model procurement code, which we had discussed a few minutes ago. Is this something, the 2000 model procurement code from the American Bar Association, you see this or saw this as not inconsistent with the district's law? Is that right?
Yes, Chairman, I believe that the PPRA and the regulations in contracting are very clear on the request for proposal process and our ability to negotiate, and also found very clear since the implementation of the CBE law, the interpretation that for requests for proposals, that the receipt of proposals is in fact the best and final proposal received. The CAB is interpreting it as the initial.
Right. So following the CAB's conduit ruling, how have you or will you communicate the change in practice to future bidders?
We already have, Chairman. We are clear in our, and as was mentioned yesterday in the industry day, to get your subcontracting plans completed and get them completed and accurate in your initial submission, as you will be found non-responsive if your subcontracting plan is not correct.
Okay.
All of our contracting officers are aware of this. The contracting officers, even outside of OCP, have been made aware of this.
Okay.
Of the ruling.
I want to notice helpful information I just got from Deputy Mayor Turnage with respect to the number of plans DC has relative to other states. He says the district's 3 health plan managed care program contains a total of 191,000 approximately enrollees, which is approximately 126,000 less than the average managed care enrollment level that other states have, with only 2 MCOs in their Medicaid program, and that the average in other states, the average number of enrollees for states with 3 health plans, like the district, has almost 3.5 times more enrollees than was the case in the district's managed care. So that is information that was helpful for me. So I wanted to share that. So looking now to the reasons that CAB sustained Amerigroup's protest, CAB found on a variety of grounds that OCP's evaluation of the offeror's proposals was unreasonable. What have you learned from that CAB decision? And I guess more specifically, what changes do you intend to make going forward so that the concerns raised by the CAB don't happen again on this or other solicitations?
I think the CAB provides an excellent service of a way for due process and a way for people to, to show their concerns. What the CAB advised the contracting officer to reevaluate 3 specific areas. The district, the contracting officer, and the team reevaluated those areas, and the effect of the results were the same scoring. The specifically an action though that I mentioned in testimony, and I think that here is the use of a facilitated tool to ensure, especially in these contracts that are very nuanced in their source selection criteria, to ensure that we're using more than a spreadsheet and using the tool such as we did here to ensure that we're capturing all aspects and
I guess let me ask a little more specifically, and I'm going to be brief because I'm going to turn to my colleague, Councilmember McDuffie. The CAB noted several determinations that did not comply with the notes taken by the contracting officer. So when a contracting officer develops a score, is that score reviewed by anyone at OCP to make sure that the notes and corresponding scores are accurate and correlate?
Yes, Chairman. Not only does the contracting officer complete their review, it does also go through a procurement review committee. It is also reviewed by the attorney from the Attorney General's office for legal sufficiency. And the CAB did find 3 areas for us to re-review. Those areas were re-reviewed, and the results were the same.
And finally on this, during the evaluation process, 2 contractors gave almost identical follow-ups in response to the BAFO, but according to the CAB were unequally evaluated. What's your response to that, and how can you mitigate unequal evaluations in the future?
Well, I would really want to understand that question in more detail of what you're speaking to there, Chairman. And I think I'm unable to give a general response here. This is still a case that's under litigation, and the details of the scoring itself, I'm uncomfortable getting into that.
All right. I'll note, though, that this is from a December opinion. So I would hope that OCP has already, reviewed that decision and really
Absolutely,
thought through
Chair.
these issues.
Yes, absolutely, Chair.
So your response then to my question that you would like more time to understand the issue I'm raising, I think it is tough to follow because, again, the issue is one raised by the CAB in December.
Well, the CAB raised issues for us to reevaluate, which we did do.
Well, that was their order, but in their findings, they found that during the evaluation process, 2 contractors gave almost identical answers to the BAFO, but they were evaluated differently.
And that was the results of the reevaluation, Chair, or that was the focus in the reevaluation, Chair.
But we have to understand why, or it's going to happen again.
That was the CAB's opinion and for the contracting officer to reevaluate. The results of that reevaluation, I'm not able to get in, so I can't describe to you, Chairman, if the CAP said that there were two that were looked at differently. I can't get into what the actual reevaluation was to tell you if it was different or not.
Let me turn to my colleague, Councilmember McDuffie. Welcome back.
Thank you, Chairman. I don't have very many questions. I probably won't take up much time. I just have been in and out of meetings, but my staff has been monitoring the hearing and brought something to my attention. So I wanted to ask about it. And good afternoon to you, Director Shutter.
Afternoon, Councilmember.
I believe that Chairman White asked earlier about the guidance that OCP provided to the bidders. I think perhaps he asked specifically about if OCP sent any guidance to MedStar about their CBE subcontracting plan. And I understand that your response was that you sent, that OCP sent MedStar the same materials that they sent all of the bidders. Is that correct?
My response, Councilmember, is that OCP sent all bidders a solicitation which describes the requirements of subcontract.
Okay, and is it your understanding that the requirements of the subcontracting were that the subcontracting plan be submitted along with the proposals at the time of the proposal submission?
That's correct, Chair. That's correct, Councilmember.
Okay, and of the three that were awarded, AmeriHealth, MedStar, and Care First, did any of the three submit their subcontracting plans at the time of the submission of their proposals?
I believe, Chairman, that all three of them submitted plans. I believe that one of them had a modified plan through the BAFO process.
Okay.
And that
So,
modified plan through the BAFO process is what now throws them out under conduit.
okay.
And so all three contracts had legally sufficient and appropriate subcontracting plans when approved.
When approved. So, but when they submitted their actual responses to the RFP, to the solicitation, all three did not have legally sufficient subcontracting plans, correct?
One of the, I think there are 7 offerers, 4 in the competitive range.
Of the three that were awarded specifically.
One of the 4 that went through the BAFO process had an adjusted subcontracting plan from their initial submission of proposal to their best and final proposal, which under the conduit ruling throws that
Right.
proposal out.
And I want to just make sure the record is clear. Now I understand what you're saying. At this, and that one you're referring to is who did not have a legally sufficient subcontracting plan at the time of their response to the RFP is which bidder?
I'm sorry?
Which bidder did not have the legally required and sufficient subcontracting plan at the time that they submitted their proposal to the solicitation?
I'm not stating on the legal sufficiency of an initial proposal. What I'm stating, Councilmember, is that there was a change in the subcontracting plan from MedStar from the initial proposal submitted to the best and final proposal.
Okay.
That change in the subcontracting plan is what throws them out.
Got it. Okay. And who requested the opportunity to change the MedStar subcontracting plan subsequent to their response that they submitted with their bid?
So all proposals are reviewed when they're received. If they're in the competitive range, if the contracting officer establishes a competitive range, the contracting officer in the district in a in a request for proposal process may negotiate either with the top offeror or with the competitive range. And what that means is that based on the technical evaluation panel's review and based on the contracting officer's review of the proposals and the district's requirements, the contracting officer may craft a letter to the proposers and say, in review of your proposals, we find these issues that could be improved. And then we invite them to submit a best and final proposal. So
Right.
every one of the offerors that are in the competitive range in this case, that had any type of a deficiency, the CO sends that to those proposers because we want to have competition, right? We want
So
to
can
have
I-
competition.
Sure. So when was the BAFO submitted? Or when was the deadline for the BAFO?
Prior to award.
What date was that?
And you're talking about which BAFO on the initial award, Chairman, or
Yes.
council member?
Yes, initial award.
I'll have my staff find that.
I'll give you a minute.
Thanks. August 11th. So May 20th, 2020.
May 20th, 2020.
Right.
Okay. And is it your contention that one of the four in the competitive range submitted a subcontracting plan that was approved then, or what exactly are you, what's your understanding of the timeline, the process with respect
So
to
in the reevaluation, Chairman, there's no question about subcontracting.
Well, I don't want to get to just share.
Subcontracting plans.
I'm talking about the original one, the BAFO in May 2020. That was the date of the BAFO, right? Was due. And did MedStar submit their subcontracting plan? And was that subcontracting plan legally sufficient on or before May 20th, 2020?
Yes, the final subcontract, the final proposals contained valid subcontract, legally sufficient subcontracting plans. That's correct.
For MedStar?
Yes.
Okay. So what exactly was the document that had been provided at some point when my staff requested copies of the subcontracting plans for the three who were awarded? There was a document that had a date of December 2020 and a signature of someone in OCP on that date. That was my understanding, that the subcontracting plan for MedStar wasn't actually approved until that time.
Councilmember, I don't know what document you're talking to. I do know that the best and final proposals that were received contained legally sufficient subcontracting plans, or we wouldn't have awarded contracts.
Can I give you a moment then to confer with your staff, because there was a document, specifically a subcontracting plan for MedStar that had a date of execution on December 2020.
I don't understand your question, council member.
Okay, there was. Can you ask your staff? Maybe you don't know the answer, but let me tell you specifically what my question is.
Okay.
What is the date that MedStar and OCP executed the legally sufficient subcontracting plan.
Well, that would have been when the contract was fully executed by both parties, which would have been after the contract went to council and was approved.
Which was when?
Would have been back in September, Chairman.
September 2020?
You're asking, council member, when did the subcontracting plan that's incorporated in the contract become effective? And that would be when we executed the contract.
Not when it became effective. I'm trying to see when when OCP actually received the subcontracting plan from MedStar that you all deemed legally sufficient and approved.
We can get you the date of the contract that was the subcontract that was executed, but I don't have that with me, Chairman.
Mr. Chairman, I know my time has expired, but I would ask if you could to get that information today while this hearing is going on. I know as long as this has been going on for as much time as you've spent on this issue, as much time as I've spent on this issue, I know OCP has a timeline where they should have these answers readily available. And I think this is a critical date around the subcontracting plan. Can I just offer one final question though, Mr. Chairman, if I could? And I think I'll be finished.
But let me just ask really quickly, Chief Shutter, is, let's say 20 minutes enough time to get what Councilmember McDuffie is asking for is a factual question. So is 20 minutes enough time to?
I guess I'm asking what the document the council member is asking for, because let me be specific in my answer here. We award a contract and it has a subcontracting plan. It has subcontracting plan requirements in it, and they're specific. Now, those plans are ultimately executed through contracts and provided to the Department of Small and Local Business. So you're asking about the executed subcontracting plan that is required by our executed MCO contract, or what document are you asking for?
So at the solicitation that you all provided, and the law in the code requires a submission of a subcontracting plan at the time that a bidder submits their response to a solicitation.
Yes.
You said that there were 4 in the competitive range. Only one of them did not submit, or one of them submitted. This is your testimony. Was one of them submitted a subcontracting plan that was later modified? And I don't want to. I'm paraphrasing here. If I didn't get that accurately, then let me know.
Well, what I would say is that the best and final proposal, that there was a legally sufficient subcontracting plan that was proposed, that was sent to council. Now,
and that happened on or before the BAFO, and I'm asking for your understanding, OCP, of the document that I received in my office upon request for the subcontracting plan showed a date of December 2020, which would have put it after the BAFO. And I'm trying to clarify that.
Okay. And you're asking about a subcontracting plan that was received by your office that was dated December 22nd.
December 2020. I'm not sure exactly what day in December, but it was dated December 2020. And this was the subcontracting plan for MedStar.
Okay.
And I believe it may have been Ms. Barber's signature, which was affixed to this document.
Okay. And I'll say again, the contract that was reviewed and that was sent to council included a legally sufficient subcontracting plan.
Which was, and that date, and I apologize, Mr. Chairman, but the date that you all sent this to council was before December 2020, correct?
It would have been before we executed the contract, Chairman.
Which was when? On what date did you execute the contract?
September.
Okay, so why then would Ms. Barber's signature, would there have been a need for her to have her signature associated with a subcontracting plan in December of that year, if the documents had already been submitted to the council?
Well, you certainly have a subcontracting plan that is submitted to, you can certainly have a plan that is submitted and even modified with DSLBD's approval. But the point that I'm making, council member, is that the contract that was reviewed and approved by council contained a legally sufficient subcontracting plan, which may or may not have been executed after the actual contract was awarded. But it is awarded, that MCO contract has a subcontracting plan that is approved ultimately through DSLBD. So after you execute the contract, there is a subcontracting plan that certainly could be executed and submitted to DSLBD.
If I could just intervene 1 second, because we've been on this issue for about 10 minutes. Chief Shutter, what I think Councilmember McDuffie is asked for is when did OCP receive what it considers a legally sufficient subcontracting plan from MedStar? Is that correct?
Through the best when we received their best and final offer.
Yeah, Mr. Chairman, I've got information that suggests there's a conflict with the testimony and the actual date where documents were executed. And let me be careful in how I phrase this. I just want to make sure that it's consistent. And
I've heard the concern as well, which is why I think this information would be helpful. So it's just a date, the date on which OCP received what it deemed a legally sufficient subcontracting plan from MedStar.
Yep.
Can you get that within the next 20 minutes, Chief Shutter?
I appreciate it, Mr. Chairman. And I know he didn't answer your question. And if he's claiming that there was a different date on which they received the legally sufficient subcontracting plan, then it would be great if he provided that executed agreement and subcontracting plan to the committee as well, so that we can see and verify the contention that he's made. That would be helpful. But I appreciate it, Mr. Chairman, and thank you, Chief Shutter.
Thank you, Councilmember McDuffie. Chief Shutter, can someone from your team get that within the next 20 minutes?
Are we able to take a 5-minute break, Chairman?
Yes, we will be in recess for 5 minutes. We will resume at 1:11.
Thank you.
Thank you. right, we are resumed. Welcome back, Chief Shutter.
Afternoon, Chairman.
I guess hopefully now within about 15 minutes, can someone for your team get that date that Councilmember McDuffie requested?
What I can tell you, Chairman, and I don't have the document that the Councilmember McDuffie is referring to, but what I can tell you is that a legally sufficient subcontracting plan was sent to council, was executed in the contract. When that contract was sent by the firm to DSLBD, there were further discussions around the plan, and the December 20 signed subcontracting plan was the results of those further discussions with DSLBD.
Okay, but Councilmember McDuffie's question was when OCP received a subcontracting plan that it deemed legally sufficient, and
That would have been in the final proposal, which was incorporated into the final contract, which was the final reviewed contract and sent to council for review and approval. And that contract contained a legally sufficient subcontracting plan, deemed legally sufficient by the AG. And that plan was further discussed with DSLBD and MedStar. And the results of that discussion is the signed contract, the signed subcontracting plan that I believe Councilmember McDuffie is referring to, that was signed in December 20.
Chief Shutter, I'm asking what was the date that OCP received what it deemed to be a legally sufficient subcontracting plan for MedStar?
The date of the best and final offer that was received, if I could have that.
Chief Shutter, I'm asking the date that OCP received what it believes to be a legally sufficient subcontracting plan from MedStar.
And that's what I'm looking for, the actual date, Chairman.
Thank you.
May 20, 2020, Chairman.
Okay. MedStar sent its legally sufficient subcontracting plan on May 20th, 2020.
That's correct. OCP received all BAFA responses from the offerors in the competitive range on May 20th, 2020.
Okay, can you send that to the committee?
Send what, Chairman?
The legally sufficient subcontracting plan from MedStar submitted on May 20th, 2020.
I will send, Chairman, if I'm able to. I believe that is part of the contract that was submitted to council, but yes, I will do that for you, Chairman.
Thank you. I guess I'm very confused why it took 20 minutes to get that answer. What am I missing?
I was uncertain of what document Councilmember McDuffie was referring to, and I didn't want to give an incorrect answer. And there are deliberations between DSLBD and providers on subcontracting plans that do happen, and subcontracting plans do change with the approval of DSLBD. So this is standard practice, Chairman.
Okay. So the reevaluation of the proposals within the competitive range that OCP, you said we had a discussion about this, that OCP began this in March 2021. So if OCP had already begun the reevaluation, why did the mayor veto a bill that the council passed requiring the administration to redo the evaluation in, I think it was July?
I certainly can't speak to that, to a veto of the bill, Chair.
Why not?
I'm the Chief Procurement Officer of the district, and I can answer any questions about the contracts at hand. I don't have an opinion on the vetoing of the bill.
All right, I can't let that slide because you're here as the designated representative from the executive. So we didn't request you specifically to testify. We sent the notice of this hearing to the administration, and the administration designated you to testify on behalf of the administration. And so if we allow sort of a practice of the representative of the administration to say, well, I can't answer that, somebody else has to answer that, then it will always be possible to elude oversight. And so for reasons hopefully you understand, you have to be able to answer questions beyond OCP.
I would state, Chairman, that when the request went over, we had to consider the potential outcomes. Then the vetoing has another consideration. As I mentioned earlier, and I'll be consistent, that it's my job and the job of my contracting officers to follow the law and the regulations on the day that those actions take place. And so if a law is passed, we follow that law. A law is not passed until the council approves it, the mayor signs it, and the appropriate days go past. So what I will tell you, Chairman, is that the vetoing, we were mindful of the law, and if the law passed, we would follow the law. The law did not pass, so we did not follow the law.
All right, you testified that OCP began the reevaluation of the bids in March. In July, the mayor vetoed council legislation to require the administration to do a reevaluation. Were you consulted in the decision to veto the bill the council passed?
No, Chairman.
Where can the public access the reevaluation? Does the public have access to the redacted document that the committee has?
That's correct, Chairman. The Contracts Appeals Board has the redacted copy on their website. And if that changes over time, if the attorneys to the parties agree, for example, to allow the language in there to be further redacted, then they will typically repost it.
Okay, so who decides on the redactions? Who makes that decision?
Ultimately, Chairman, it's a discussion amongst the attorneys that are party to it, and ultimately, I believe the CAB makes the final determination between adjudicating between those parties.
Can you help us understand? It took a long time for us to get even this highly redacted version of the reevaluation. Why wasn't this released sooner?
I requested, Chairman, myself very early on for a public version of this with as least redactions as possible. I cannot speak to the time frame that it takes the attorneys in the CAB to decide what actually gets redacted. It's certainly nuanced and under litigation, so there is time involved in ensuring the rights of the parties in their current and future litigations.
Okay, so we got access to it on September 30th. That was that timeline had only to do with the CAB.
Chairman, I asked Yes, that is correct.
Okay. So you, yeah, and probably not entirely relevant. I got the date. We got the redacted version after September 30th. That was the date of the expiration of the contract. So I want to correct the record. Not that it changes any of the surrounding discussion. Chief Shutter, you testified about DHCF's notice to the council on August 20th, 2021, that MedStar was ending its provider agreements with CareFirst and AmeriHealth, and the result would be, quote, the loss of healthcare services to many district residents, end quote. How do you square that a notion with MedStar's testimony earlier that it did not intend to have this impact?
I'm not sure I'm understanding your direct question, Chairman.
So your testimony stated with regard to MedStar ending its provider agreements with CareFirst and AmeriHealth, your testimony indicated that it would result in, quote, the loss of healthcare services to many district residents, end quote. MedStar testified that it did not intend to end its provider agreements, but rather was just engaging in what is, they said, their normal negotiations. So I'm trying to square these two notions.
I believe, Chairman, if I heard the testimony correct, I see it is one and the same. There is the declared emergency and the detail around our 250,000 beneficiaries and the effects of that. And then the testimony that I heard today is that was a course of business, the timing with that. Regardless of the course of business, we take into account the declared emergency and the actual landscape, Chairman.
Okay, I get. All right, let me ask it maybe more clearly. Your testimony says on August 20th, 2021, DHCF notified members of the council that MedStar planned to end its preferential pricing agreements with Trusted CareFirst and AmeriHealth. MedStar testified that they did not intend to end their relationships with these providers, simply to renegotiate terms. Is it your understanding that MedStar did not intend to end its partnership with other MCOs?
I think it's factual at that moment in time that there was not an option period that would be provided. And so what I heard from the testimony from MedStar was that with that option not being provided, they then closed those agreements. But what MedStar did with the sending of those letters did not affect the contracting officer's decisions.
MedStar testified that they quickly got word out that it was incorrect, that they were ending its relationship with other MCOs. Are you aware of MedStar quickly correcting the record on that issue?
I do not know that detail, Chairman.
Okay, that is to say you are not aware of them correcting the record immediately.
That's correct, Chairman.
To your knowledge, has the administration ever before assumed authority to unilaterally ignore the PPRA and break a standing order of the cab?
I'm not aware of the administration doing that, nor is that anything that I or my contracting officers would do.
Does the mayor have legal authority to override the PPRA and break a standing cab order?
There's what overriding of the cab and breaking of the PPRA are we discussing, Chairman? Because the
The
district.
mayor's September proposal to override the cab and break the PPRA to extend the contracts that the cab had already ruled on in December of 2020.
As I note in my testimony, Chairman, there was an reevaluation as was required by the cab. That reevaluation was scored and documented through a business clearance memorandum that was submitted prior to the exercising of options to the Attorney General, and the Attorney General's team turned that around to the cab. The cab worked with their attorneys and have publicly noticed that. The actions that the contracting officer took regarding the declared emergency were actions that the contracting officer took. So I am not aware of a violation of the PPRA, nor any improper actions that the district took against the cab. The contracting officer in the district took the actions that the cab did request the district to do.
So what was the point of the emergency declaration then? If it seems, according to your answer, it seems that that was unnecessary.
Chairman, the contracting officer in the district, we took actions in order to mitigate the challenges declared in the declared emergency.
I don't follow.
There's a declared emergency, Chairman. The emergency was regarding 250,000 of our residents, some of the most vulnerable. Therefore, as I mentioned before, my contracting officer and I have to take into consideration industry, the landscape, the laws, the regulations, and the current environment. There was a declared emergency, and the contracting officer took the actions that were needed to protect the 250,000 residents in their healthcare in order to mitigate the declared emergency.
Why was there an emergency?
The declaration of the emergency is public record, Chairman.
Why was there an emergency?
There was a declared emergency. It's public record, Chairman.
Is it that you don't know why there was an emergency, or I mean,
There's a declared emergency. The emergency was declared in order to ensure that 250,000 residents, some of our most vulnerable, do not lose their medical, their medical and Medicaid insurance, Chairman.
And the declared emergency was going to extend the contract of MedStar. Is that right?
No, the declared emergency describes the vulnerabilities of 250,000 residents with the degradation of their healthcare. And in order to ensure that that healthcare did not degrade, we took actions in order to solidify the healthcare market. At the same time, the district, now incorporating behavioral health, is resoliciting our MCO requirements with behavioral health that they incorporated into it.
So it was not the intention of the administration to extend the contract with MedStar?
There was a declared emergency, Chairman, that described the challenges for 250,000 residents. I and my contracting officer took the actions that were necessary to ensure that contracts were in place to support those beneficiaries through a declared emergency.
Was there an intention to extend the contract with MedStar?
My contracting officer and I took the appropriate emergency actions for contracts in order to meet the declared emergency.
Was there an intention to extend the contract with MedStar, Chief Shutter?
In tension with who, Chairman?
Chief Shutter, do you not understand the question?
I
I don't understand why we're going in circles for things that are factual questions. Either there was an intention or was not an intention to extend the contract with MedStar, and you're deliberately going on tangents instead of answering the committee's question.
Chairman, I am answering as specifically as I can.
This is a yes or no question, and that is the specific answer. Was there an intention to extend the contract with MedStar?
There was a declared emergency, and we took the proper contracting actions in order to mitigate that declared emergency.
Why are you refusing to answer the question?
I'm answering the question straightforward as a public servant in the actions that were taken by the contracting officer.
This is a yes or no question, Chief Shutter. Was there an intention to extend the contract with MedStar?
I had no intention to extend a contract with MedStar, Chairman. We took contract actions in order to meet the declared emergency.
And what was the basis of the declared emergency?
It's documented in the declaration itself, but the basis is to ensure that there is a continuity of care for 250,000 residents.
Here's why I'm frustrated here, because the CAB ruled in December, ordered a reevaluation. The council requested a reevaluation. There was nothing but opposition from the administration. Today, you're testifying that the reevaluation actually began in March, but we didn't receive, the council and the public didn't receive any notification of a reevaluation until the end of the summer, when it was too late for OCP to do a resolicitation. Then it became, because it was too late for OCP to do a resolicitation, it became impossible to create any stability for Medicaid and Alliance patients. And so now we're trying to factually understand what happened, one, for transparency and accountability, but also to make sure we don't do these things in the future. And it is very difficult to get answers to factual questions. And so, Chief Shutter, I'm not sure, sort of, clearly there was some coaching in what to answer and how to answer it. I can't say that I can follow the reason for it, but I do want to make clear that we're trying to get clarity and transparency, and your answers are very evasive here for reasons that I hope that you will explain.
Chairman, I actually have been very direct and very specific in my testimony and in my responses. And the results and the execution of the contracting actions that the district took were in line with the CAB. The CAB asked the contracting officer to reevaluate prior to exercising option periods. The contracting officer did that. There was no requirement in the CAB or from anyone else to resolicit. And so the resolicitation is a factor of a change in scope and adding in behavioral health services. So in fact, as I laid out as clearly as I could in testimony, Chair, this is a large procurement. It is a nuanced procurement, and it's for $1.5 billion. And so there's a lot of interest here. My job, the job of the contracting officer, is to understand the district requirements, understand industry, follow our laws and regulations. And there has been many proposed legislations that were involved here, we have to consider those things. And as a public servant and as my contractor, I'm proud of OCP, working through a very fluid environment and following the law and regulations and following the requirements of the CAB. We followed the requirements of the CAB. There was a declared emergency to protect 250,000 beneficiaries. And I took, and the OCP took the actions appropriate under the law, under the regulation, to ensure that we have ongoing services for some of our most vulnerable population. So my intention, Chairman, is to follow the law. That's what I do, and that's what I will continue to do.
I see it differently. I think the emergency was not a real emergency. It was a manufactured emergency to allow the administration to ignore the law. And the reevaluation could have been done much sooner and avoided a lot of this instability, but it was not. One of the issues that's been discussed today is the question of whether MedStar has too much market power and can essentially destroy our healthcare system if they're not selected to participate in the next, or if they're not selected as in the next solicitation, in the next procurement, or don't have contracts with the other organizations. What is your view of MedStar's sort of market power as it impacts our MCO? Do we have a viable managed care program without MedStar?
I would. So, Chairman, we have an ongoing managed care program that has been continuous and I think has served our residents well. We have a new solicitation that will be hitting the streets here in November that will have the requirements of the district, and we'll follow those requirements. And anybody that is in the marketplace that is able to propose, they're welcome to do that. Who is in the marketplace, who proposes, who does well at proposing or not against the district requirements is really up to industry. I hope, and my objective is to get as much competition as we can, so that we can provide the most innovative and best solutions to our residents.
Do we have a viable MCO program without MedStar?
When we make decisions on contracts, Chairman, we make those decisions at a point in time. Right now, MedStar is a part of the current program.
We have had several reprocurements that were either directly or indirectly caused by MedStar's market power. And so it is, I think, an important question to ask whether or not we have a viable MCO program without MedStar.
Actually, Chairman, if we look in the past, we have had programs with and without MedStar. So I would say that certainly in the past has been viable.
Okay, so when MedStar was not an MCO contractor or contracting with providers, we've had that in the past?
Yes, we have had MCO programs without MedStar in the past.
Okay. So even with MedStar was not contracting with the providers.
There have been MCO programs in the past that did not contain MedStar as an MCO.
But I'm asking, without MedStar having agreements with the MCO providers, have we had that in the past?
We have had, I am not aware, Chairman, of the details of the hospital agreements between providers and hospitals over the past number of years, but we have certainly had MCO programs without MedStar holding an MCO contract.
Okay, the only reason we engaged in the discussion about the past is that that's where you went with your answer. So let me go back to my question then, which is, do we have a viable MCO program if MedStar does not participate as a provider or contract with the providers?
We currently have a viable MCO program, and if the industry changes and if the marketplace changes, we will make the best decisions based on who proposes and who does not. But we currently have a viable system that is working.
Does the current system include MedStar?
MedStar is one of 3 MCO holders. That's correct.
Okay, then it's not relevant to my question. My question is whether we can have a viable MCO program without MedStar participating as a provider or having an agreement with the providers.
And my response, Chairman, is that we've had it in the past, and I
without
can't.
MedStar as a provider or an agreement with the providers.
I do not have the detail of the agreements with the providers. We have.
Okay, then if you're not sure about that in the past, then please don't refer to the past in your answer. I'm asking if we can have and this is an important question, Chief Shutter, because if we can't have a viable MCO program without MedStar, the city deserves to know that. So if you have an answer to this, I hope you'll answer it. I don't know the answer. We're relying on you.
And my answer, Chairman, is that we do have a viable program, and we have had viable programs in the past without MedStar having an MCO. And I am confident between DHCF and the district and OCP that we will continue to put the district in the very best place that we can. I can't speculate, particularly with a solicitation that's going to go on the street. I'm not in a place where I can speculate on who may receive future awards and how the marketplace may shift based on one contractor or another. So what my answer, Chairman, is that it has worked in the past. I can get back to you on the detail of the hospital agreements that we have no privity with and respond to that. But I'm not able to give you a speculative answer on who might receive awards because it may be even perceived as that. So I'm cautious about giving a speculative answer, given that we have a live procurement, Chairman.
So from a policy standpoint, what should we do as a city? What should we do if we can't have a viable managed care program without MedStar either as one of the MCO contractors or having agreement with the contractors? We don't know the answer to that. I mean, this is an important question, and your response is that we don't know.
Chairman, I would, and I do think these policy and programmatic discussions would best be held with DHCF.
Then the administration should have sent DHCF because we were very clear about what this hearing was going to be about. Ambrose Lane testified earlier about procurement models in other states like Maryland or South Carolina, indicating that they have sort of an independent arbiter that sets the rates for MCO contracts. Are you familiar with how Maryland and South Carolina handle their MCO programs?
I am not familiar with that, Chairman, but I do know that the rates are highly regulated, including by the CMS and the feds, the federal government.
With the upcoming solicitation, what if anything will be different than the past solicitations with respect to this the upcoming MCO solicitation?
So there will be behavioral health that is incorporated into the new solicitation, Chairman. It will also be I'm sorry, do you have a question on that, Chairman?
Yeah, I'm sorry. I mean process, not the substance of the contract, but in terms of the procurement process, how will the procurement process be different?
Yep, procurement process, we will follow a procurement process with an integrated procurement team that is on a daily focused on working through developing the solicitation, engaging with industry such as the industry day yesterday, and laser focused on getting a request for proposal on the street prior to November. This integrated procurement team has the benefit, though, of periodic, often periodic discussions with senior leadership to make sure that we're on track with the procurement. And if there are any issues that may delay the procurement that can be worked, that we're focused in on top of that. So we have a milestone plan. I'm confident that the resources that have been brought together for the team, both in the day-to-day as well as the ad hoc is needed, from legal to leadership to behavioral health, as this is a new part of the requirement. That team has the people necessary to keep the procurement focused and keep it on track.
Of that response, what is different than the procurement process last time around?
I would say what is different is is a regimented review, regimented weekly review of the progress of the team.
Okay, so an internal review, that's going to be the difference between the last procurement process for the MCO contract and this time around.
We have a new contracting officer that has been established in there have been behavioral health experts that have been added to the team. We have had discussions and are assured by our attorney general that the attorney that is engaged in the pre-solicitation activity will continue with the team, that they'll be part of the review all the way through the procurement review committee prior to making final decisions. So deliberate focus on not only the resources, but consistency of the resources, and a highly in ensuring at the highest levels that the team has what they need to stay on track.
One of the things that we've tried to sort through, and I appreciate MedStar being here to give its perspective, and I am hoping and expecting they're going to send the follow-up that we requested, because I think it would really support the argument that they made that what they did was not a threat, but was their normal sort of renegotiation process. But is that question as to whether MedStar's actions with respect to MCOs, other MCOs being able to utilize their facilities and physician networks, is that relevant to OCP's procurement process?
Those agreements, it depends, Chairman. Those agreements, those hospital agreements, are between the providers and the hospitals. The district's not a party to those agreements. So those agreements are negotiated between those parties. If the Attorney General or another body said that the dealings between those parties were improper, then yes, we would we would take that into consideration. But ultimately, it's up to the businesses to negotiate their rates.
Okay, I guess what I'm asking is MedStar has good standing generally in the district. However, if what they did this summer was to threaten to withdraw their complete participation from Medicaid patients as a result of not getting a contract, my question is, what, if any, impact would that have on OCP's evaluation of MedStar as a bidder?
If it was determined that anything was done improperly or illegally in those actions, then that would affect the responsibility of the company. Responsibility is a term used that the contracting officer makes a determination that the company is responsible, that we're able to do business with them. And so, for example, if there was a body that found that there was something nefarious between those agreements, or that there was a violation of the law, those things are a consideration when we're considering all things when it comes to the responsibility of a contractor.
Okay, so if MedStar threatened to not allow other MCOs to utilize its physician network or facilities, you would not see that relevant to MedStar's selection as a provider in the future?
I would say that if there is a violation of the law between
only if they violated the law, but if they threatened, if they did in fact make a threat, but it didn't violate the law, then it would not factor into the selection process.
I would say ultimately the negotiations between two parties that determines that agreement, and if there is not a violation of the law, or that's between those two parties.
All right, I see it differently. I think this is relevant to the people that we serve, right? Vulnerable people. And if MedStar did make the threat that has been claimed, then we have to evaluate how comfortable we feel with them serving our vulnerable population. If they did not make that threat, and they're going to submit information to substantiate that, then it is not relevant. But I see that factual question is very relevant to how the city engages.
And I'd say the chairman, like all public procurement actions, is there is a lot of statute and regulation and in court law, court cases around, and I will continue, and contracting officers will continue to follow the laws and the regulations that are in place at the time that we make our contracting decisions. And if there is any violations, or if there is any issues that would appropriately affect a company's responsibility, then we follow that law for all companies, Chairman.
If past practice of a contractor is not good, does that mean that they violated the law?
There is a. Are you speaking to the concept of past performance, Chairman?
Yes.
So there is past performance that is considered, and oftentimes in district solicitations and RFP process, we will request from other providers that provided similar work. We will ask them their opinion on the performance of the contractor. So that is one way that we determine the past practices of a company. We will look at federal debarment. We will look at the district debarment or suspension. We'll look at Dun & Bradstreet, and what is are there filings of the company against the law. So there are a number of factors. Again, this is steeped in statute and regulation, and in highly adjudicated through the courts. How you treat responsibility and past performance fairly across the board. It's important to me that we are following the law and the regulations and applying that equally.
The timeline for getting a contract to the council in June of 2022, how would that timeline change if the initial award is protested?
Well, the initial award, conceptually, Chairman, would be made in June. And then the district would make a determination if we would move forward with those contract awards in light of the protest or not. If the district determined to move forward, then the protester would have the option of asking the CAB to stop. Ultimately, the CAB would make a determination if we would stop those contracts or not. If they are stopped, then the district has to take the appropriate actions to continue with Medicaid services for our residents. So it really does depend, Chairman, on when the protest takes place, the veracity of the protest, whether the protest prevents the contracts from moving forward or not. Protests can also happen at the solicitation phase. And you have a good understanding of that after the solicitation is announced and when initial proposals are received.
So when the contract is awarded in June of 2022, if it is protested, which most contracts are, it is up to the CAB as to whether the contract can proceed while the protest happens. Is that right?
The contracting officer works with the program to determine if it's in the best interest of the district to proceed. That is ultimately determined by the chief procurement officer to move forward with the contract while under protest. If I agree to that, then the CAB and the protester have the opportunity to go to the CAB to request the work to stop. And the CAB may or may not stop the work.
Okay, and how do you evaluate whether something is in the best interest of the city to proceed when it's after a protest is filed?
Discussions with the attorneys, including the Attorney General, on the likelihood of the case, the veracity of the case, an understanding of what's happening in industry and what is needed for the requirement, the ongoing requirement of the district, or things that I contemplate. I contemplate significantly the thoughts of the contracting officer here and their desire and their opinion.
But won't the contracting officer always say that their,
No,
process was correct? No.
No.
Okay. So there are instances in your tenure where there's a protest and the contracting officer says to you, yeah, we might have messed this one up?
There are instances, Chairman, where the CAB will say there's a protest and that we do not move forward.
I'm sorry?
There are instances where the CAB will say to stop and that we do not move forward. And I take a lot of things into consideration as far as I think you said the contracting officer screwing up. There are very few cases that in my 7 years here, Chairman, I think on my hand I can count of sustained protests with the CAB. So that wouldn't be my first thought that we screwed up. My thought would be about making sure that the contractor gets due process. Is the needs of the district to push forward on this urgently, or do we let due process go through?
Okay. Well, my first thought wouldn't be that the contracting officer screwed up either. I was trying to understand your answer where you said you give a lot of deference to the contracting officer. I asked in response if the contracting officer might advise you that no, we should. Why would a contracting officer advise you that that the contract should not move forward once it's protested, other than a mistake in the procurement process? Why would they advise you that?
Well, because the requirement is not that urgent that we need to continue until the due process that rightfully should take place takes place.
Okay, and so
for
that's
example, Chairman, if we're buying a new system.
no, I'm with you. Don't need the example on this. So the contracting officer would know that better than the programmatic person.
Well, the contracting officer is the person that's working with the program manager. And so the contracting officer with the program manager is going to write the determinations and findings for me to approve for them to continue. So I guess inherently what the contracting officer states matters, because I wouldn't move forward unless the contracting officer believes that we should move forward. And that contracting officer is going to be thinking about the district requirements, discussions with their legal counsel, and how important it is from a timing perspective for the program to move forward or not.
All right. Chief Shutter, those are all the questions that I have today. I want to thank you for being at this hearing on behalf of the executive. I also want to note that anyone who was not able to testify but who would like to submit written testimony may do so. You can email that to the committee at facilities@dccouncil.us. The record for this roundtable will close at the close of business on Friday, November 12th, 2021. So with that, let me also thank public witnesses today. On the business before this committee is concluded. The time is now 2:04 p.m. and this roundtable is adjourned. Thank you,
Chairman.
Thank you.